And if not reducing the incidence, at least we can detect the cancer early so that it is in the curable state. So in this background, I would like to start regarding some basics of the cancer. So as we all know, our human body, the cells, which is the structural and the functional unit. And in the cell, the cellular environment have been changed by the various external factors. For example, various pollution, alcohol, tobacco, etc. We know that in the cells there is a one organelle called the DNA. So when there is a damage of the DNA occurred, there is a abnormal or enormous proliferation occurred in the cells, and ultimately it leads to the cancer or malignancy. So where this cancer comes? So cancer is a Latin word of carcinos. Carcinos is the means a crab. So crab having a various tentacles, so it's spread outsides. So like the same way the cancer spreads, that's why the cancer word come from this carcinos word. So cancer regarded as a group of disease which are abnormal growth, invade the tissue and eventually death of the individual person. So this is a global cancer observatory, or we can say the Globocan data of Indian data of 2022. It is seen that more than 14 lakhs of the year incidence of the cancer all over. Now, if you can individualize between the various genders, male and female, you can see in the female, the breast cancer is the most common, followed by cervical, that is the cervical cancer. So you can see the total number in the breast cancer near about the 2 lakhs, and cervix cancer near about 1,30,000. So it is a huge. Coming to the first, the cervical cancer. What is a cervix? So cervix is the lower part of the uterus. So it is a part of the woman reproductive organs. So there is various risk factors of the cervical cancer. So some are avoidable risk factors, some are non-avoidable risk factors. So among the avoidable, important is the early onset of the sexual activity, multiple sexual partner, high risk of sexual partner, and the STD or sexual transmitted disease. Other few things are there, for example, cigarette smoking, using of the oral contraceptive, these also adding the risk factor or avoidable risk factor of the cervical cancer. Another important virus, which is really a major risk factor, which has been established just 2 decades back, that is the HPV. That is the human papilloma virus. I am coming after a few slides. So if you can see the cervical cancer prevention, one is the primary and the secondary prevention. So what is primary prevention? Primary prevention is nothing but you have to stop smoking, use barrier contraceptive methods to reduce any kind of STDs, and important thing is the HPV vaccination, that is the human papilloma virus vaccination. So what is HPV? So HPV is a DNA virus which entered into the cervical tissues mainly through the sexual contact, and ultimately it integrates inside the cervical cells and causing their proliferation, and ultimately cancer occurs. So this is one of the major risk factor of the cervix. So if we can, like the other vaccines, if we can have such a vaccine which, if even the HPV is went to the cervical cell, ultimately there will be no cancer. So yes, there is a lot of vaccines. Mainly the two is established. One is Cervarix and the one is the Gardasil. So Gardasil 9, which is used nowadays. So the recommendation of the using the HPV vaccination Gardasil is that you have given the 2 doses, mainly from the age 9 to 14, and in case of the 15 to 45 years, you have to give the 3 doses. In India, there is also an indigenous vaccine have been developed, which is called the Servivac. So it is a quadrivalent vaccine and it is not that costly, and it is really effective from the Serum Institute of the Pune. So HPV vaccination is important. So it is various program is going on also in India to vaccinate the individuals, the women, mainly in the early age. So important thing is that more early one women get vaccinated, the more effectivity is the vaccine. Now coming to this is all the primary prevention. Now suppose we have to shift to the secondary. That is if we cannot prevent it, at least we can detect it early. So screening is the early detection tool. So screening is the test to find cancer or any other disease early in the people who have the no symptoms. So if you can see this kind of graph, so usual practice is that when the patient comes to the doctor with kind of a symptom, but when we can trace that individual before the symptoms appear. Now here the starting of the screening has started. Sorry. So this time it's called the lead time. So in this period, the cancer might shifted from the stage 1 to the stage 4. So here if we can start screening, we can detect in the stage 1, and which is a curable one. So what are the screening tool for the cervical cancer? One is the visual inspection acetic acid. Is a very low cost thing, which is initially brainchild of the Tata Memorial Hospital, Mumbai. And second is the cytology, the pap smear, and third is the HPV. So in the visual inspection acetic acid, what we have done, it is acetic acid which has been inserted in the vaginal epithelium or cervical epithelium, and if there is a color change is there, we can predict there might be a chance of a malignancy. Cytology is a kind of the similar thing. Through the spatula, we have to take some smears and we have to see under the microscope whether any kind of abnormal cells is present or not. These two have a low sensitivity. That's why the WHO now recommended the HPV testing is the primary screening test, and this should be started at the age of the 30. And every 5 to 10 years this screening to be done, and one individual in their lifespan have to take at least 2 to 3 times of the screening for the cervical cancer. After 65 years you have to stop this screening. Okay. National Cancer Grid, which is kind of a NCCN or the ASCO of US. So this is our Indian program. So in National Cancer Grid recommended VIA, that I have already told you, that visual inspection acetic acid, as in the low resource setting. It is also effective, but the sensitivity is low. In our hospital at Tichchandra National Cancer Institute, from 1999, we have started this screening program, and there are various screening programs still is available. So anyone who is interested for the cervical cancer screening, she can land up in our hospital, though our gynae oncology department is taking care of this screening program. Now, even after the screening and everything, a woman having some kind of a symptom. So how could you predict that you might be having kind of a cervical cancer, or there is a symptom? So the symptoms mainly the heavy vaginal bleeding during the sexual intercourse, blood tinged in the vaginal discharge, fatigue, pain in the pelvis, lack of appetite, something. But important thing is that, so if such symptom has come for a woman, then it is not that she having the cervical cancer, but she should rush to a doctor to see what is the diagnosis of it. So cervical cancer present with this kind of symptom. So if any kind of symptom occurred in an individual woman, then she should not ignore the symptom. So this is in short my cervical cancer awareness and the screening. Next I will go to the breast cancer. So why it is important? Because the breast cancer is the most common cancer of the female in India. So we have to reduce the incidence, or we have to detect the breast cancer so that we can treat the patient and in the early stage. Again, coming to the risk factor. So in the risk factor, there are also some avoidable risk factor, some are non-avoidable. So in the avoidable risk factor is the lack of exercise. So diet, if you can consider for a fatty kind of diet, obesity, this ultimately lead to a breast cancer, and there is a positive correlation between the fatty diet, weight with the breast cancer also. Smoking and alcohol, absolutely, and the hormone replacement therapy. So any individual woman, to reduce their menopausal symptoms, they have taken this kind of a hormone replacement therapy, but it ultimately leads to malignancy in the breast cancer. So be careful, and when you are taking such things, then you have to show your doctor periodically. Some are the non-avoidable risk factor, for example, age, family history, any genetic history, and any defective gene. I will come in the defective gene later. So the primary prevention again, so how to prevent it, get to stay healthy weight, be physically active. Important thing is the breastfeeding. The breastfeeding, there is a, when the women who have breastfed women, they have the incidence of the breast cancer is reduced in those individuals. Not using hormone therapy to deal with the symptom of the menopause. But in the breast cancer, there is no sure way to prevent the breast cancer. But there are things all the women can do to reduce their risks. Like the cervical cancer, we have a vaccination. In the breast cancer, we don't have such a vaccination, but we have a tool that is called the screening tool. And this screening tool is really robust in the breast cancer. Now the screening methodology, what are those? One is the breast awareness. So patients' familiarity with their breast, regular clinical examination, clinical breast examination and the risk assessment, and the breast imaging, that is the mammography. Now we are considering there is a two terminology here. One is the clinical breast examination, one is the self breast examination. So what is clinical breast examination? Which a healthcare professional do to a woman to detect any kind of abnormality. But the self breast examination is the something the woman individual should do by their own once a month at the home. So how the self breast examination to do in the home? So there are the four ways, as you can see in the picture. One is you have to stand before the mirror and look at the breast. Looking at the mirror, raise your arm and rest hand behind the head, and you have to see the breast, anything abnormality present or not. Raise your arm and use the pads of the 3 or 4 fingers. So you can use the palm of your 3 or 4 fingers, and you have to rotate over the breast. Okay. By this way, you do the same thing when you are in lying down position. My fourth component of the picture. So in all this here, you have to see these things. Lump, if any depression present or not, any discharge present or not, any erythema, that is the redness is there, inverted nipples present, eczema or the ulcer. You have to look these abnormality during the self breast examination. Important thing is that a self breast examination is recommended every month after 5 days of your menstrual period. Don't do before that or after that, because that time the breast would be the more proper time for the self breast examination. Next is the mammogram. So mammogram is a X-ray of the breast. This is nothing, and by mammography we can see if there any kind of abnormality present in the breast or not. In Chittaranjan National Cancer Institute, we have a mobile mammography unit. So this unit normally goes to the various camps. They screen the various women there, and we have screened patient come to us with only a stage 1 breast cancer treated and cured totally. So this is important. If you don't access to this mammography van, then you can go to any doctor or our hospital to check what is the mammographic scan is telling. Now the screening recommendation. So who have to screen for the breast cancer? All women age more than 40 years. And how? By the clinical breast examination by the doctor, annual screening mammogram, that is the X-ray of the breast, and also there are some breast risk assessment. These all are done by the doctors. But more than 40 years is fine, you are doing all these things. But you should not stay idle after 25 years. In the 25 to 39 years, you have to consider yourself for the self breast examination and also the primary prevention, that is the stay healthy always. Now one of the most complicated and important part of here, breast screening, that is the genetic testing. Cervical cancer, it is not at all a genetic disease, but breast cancer, up to the 10% of the breast cancer there is due to the specific mutation, the breast cancer might occur. So it is a kind of a hereditary thing. So one of the important gene is the BRCA1, that is BRCA1 and 2 gene. So the patient or the individual having the BRCA1 gene having a 50% chance of the getting breast cancer and 75% of the chance of getting the ovarian cancer. So who are eligible for the BRCA1 or 2 test? Now first thing, what is the BRCA test? So this is simple a blood test. So from the blood we can detect a germline BRCA1 or 2 mutation. So who are the eligible? Family members with a inherited harmful change in the BRCA1 or 2 genes, personal or the family of the breast cancer less than 50 years, having a family history of the ovarian cancer, or having a male kind of the high risk prostate cancer in the family. They should go for the check the BRCA1 and 2 gene in their blood. Now screening of the BRCA, now suppose some individual having a BRCA1 and 2 positive. So how to screen them? Is it the same as the normal individual? No. So in those cases, the breast awareness starting at the age of 18, clinical breast examination from the 25 years and mammogram for the 30 years, and also screen for the malignancies like melanoma and the pancreatic cancer. Important part of this BRCA1 and 2 gene who get positive is the surgical prophylaxis. I think everyone knows this individual, this actor. So she is the Angelina Jolie. Okay. So 10 years back, she has her mother has detected a breast cancer. So her mother tested positive for the BRCA1 gene, that is the BRCA1 gene. She undergone the same test, positive for the BRCA1. At the age of 37 years, she underwent 2 surgeries. One is the breast reduction mammoplasty. Second is the bilateral salpingo-oophorectomy, that is the excision of the ovary. So the 2 treatment is approved all over who tested positive. There are some guidelines, I'm not going to details of it. So the 2 surgeries, one is the BRM, that is the breast reduction mammoplasty, and the RIX reduction salpingo-oophorectomy. She has done the both, and as you all know, she is absolutely fine. So this is important. Those who are positive for the BRCA1 and 2, they have to screen, and they have to, and if possible, then consider for the surgical prophylaxis. Again, like that of the cervical cancer, if you have the following symptoms, you should rush to a doctor. For example, any bloody discharge, any lump, any pitting in the breast skin, pulled in nipple, or in the change in the breast color. So these are all the cancer symptom, might be a cancer symptom. Again, it is not that if you are having such kind of symptom, you have the breast cancer, but you have to rush to the doctor to show that there is something problem in the breast. In our hospital, we have just started a cancer detection clinic. So we named it as a preventive oncology and public health. You can see the scope of the service here. One is the preventive health checkup, vaccination, that is the HPV vaccination, mental health counseling, health promotion, and the tobacco cessation. Important thing is that if you can consider various other diseases, for example, suppose hypertension, diabetes mellitus. So these are not the curable disease. If you are having a hypertension, you have to take the medication lifelong. But the cancer is such a disease, if detected early, it can fully curable. Stage 1 and stage 2 cancer, if it is a head neck cancer, cervix cancer, or breast cancer, it is fully curable, and the patient comes in the normal follow-ups even after 10 years, 15 years, 20 years. So this is a fully curable things of disease, not like the other chronic disease. So whenever there is a symptoms, please go to the doctor, and whichever the screening methods is available in our country, for example, breast or the cervix, you have to go to the doctor or the proper hospital considering for the screening so that it can be detected early and treat properly. সুস্থ থাকুন, সচেতন থাকুন. Thank you.
I think we really need him after also, not today, maybe a regular sort of awareness program from the university, because I think it's very important to know. And also, I would invite, or rather I would like to invite, if the other departments help me, the bigger one, that means the partner of the, if there's a partner or anybody, you know, because that person is very important to any kind of this kind of situation where we are not actually able to handle at home. আমরা যেটাকে ফার্স্ট এড বলি সেটা আমরা করতে পারি না। আর দু নম্বর কথা হচ্ছে যে জেনারেলি আমাদের দেশে কনসেপ্ট অফ হেলথ নেই এখনো, যেটা আছে সেটা হচ্ছে ইলনেস। আর উইমেনের ক্ষেত্রে ইলনেসটা যতক্ষণ পারি করে যাচ্ছি, দ্যাট বিকামস এ রিয়েল হার্ডশিপ। আর যে উইমেন বাড়িতে সব কিছু করতে পারে, আবার ইউনিভার্সিটিতেও সব কিছু করতে পারে, তাকে আমরা সুপার উইমেন আখ্যা দিয়ে তাকে এক্সপ্লয়েট করি। So I'm against this exploitation. Nobody should be super, should be humanly. কত করা যায়? সুতরাং আমার মনে হয় পাপিয়ার প্রশ্ন থাকতে পারে। আচ্ছা, পাপিয়াকে ওই মাইক্রোফোনটা দিয়ে দিতে। আমি এক মিনিট ওর পরিচয়টা দিইনি, ডক্টর পাপিয়া মজুমদার ইন কেমিস্ট্রি ডিপার্টমেন্ট, শি ইজ এ ফ্যাকাল্টি।
Yeah, so the vaccine which is now here available is the Gardasil 9. So it is a kind of a multivalent vaccine. It should be started from the 9 to 14 years, the age group. Okay, so should be started at the 9 years, 2 doses to be given. Okay, if it is more than 15 years, then 3 doses to be given. The crux is that more early a woman get vaccinated, more chance of the protection is there. Suppose you are a lady or a girl taken vaccination at 9 years versus a woman taken at 30 years, the effectivity will differ. Okay, so WHO has recommended, that's why from the 9 years even she can take a vaccine, 2 dose only. Okay, so whoever is there, any lady or anyone, they have to take, and it is available everywhere. You can go any gynecologist, you can come to our hospital, it is absolutely available, the vaccination.
Dr. Nuju, and that brings a social question on my part. If that is the case, that we go as low as 9 years, who will be able to afford them in India? We cannot consider your institute type of where people from distant villages have to come stay at Kolkata. So what can be done if this is this much? I saw in the Google it's about 63% running the increase rate of breast and cervical. Cervical is 1 point something more, 64 something. So if that is the case, this is talking about whole India. What happens in the rural India, যেখানে এখনো প্রাইমারি হেলথ সেন্টারটা ভালো করে চলে না?
So regarding the HPV vaccination, in our health program, it is not included till now. This is bad thing, absolutely. So might be it is going to, because we have already a Indian version of this vaccination, which is cost around 1,000 rupees, but still it is high for the rural population, I am telling you. Yes, so yeah, right out to the 2000 Cervivac 2000. So I mean, in few centers you can get some in 1,000 or, but it is costly, absolutely costly. So the FOXI, that is the Gynecological Society, they are putting a pressure to the Indian government to make it available, so that it will be in the health program. And so initially it has started for a business purpose. Typical, I am telling you, in 2005 the Cervarix, which is the bivalent vaccine, started in the whole world with a business purpose, but it is not that effective. That ultimately came the Gardasil 9, which ultimately prove a effective and 99% protection if it is given a 9 to 10 years of an individual. Okay, so yes, you are right. We have to include it in our program, but there are some places in the central government institute like ours, so they are providing this vaccination. Yeah.
Hey, microphone. People, there's a Facebook live going on.
So I just want to maybe if you can help us in any ways. You mentioned about the bus, right?
Yeah.
Yeah, if by any way in future we can have that because we have got a number of
Okay.
faculties and our
So,
and we are very good
so
in ignoring ourselves.
So I would like to tell you this bus is mainly for our medical camp. They are going various rural places. Okay. Yes, we can. I mean, there might be a kind of a program. We can send the bus to this hospital, and you can consider the screening program, screening mammogram in that area. But our hospital is just 5 minutes. Okay, so you can just here, you can walk here from 2 kilometers is good for health also. You can come here. We have already I have told you the preventive oncology. It has been going to be inaugurated in 11th of March. That is the after 3 days. Okay, we have a 2 days clinic of Tuesday and Thursday. There is one dedicated doctor for these preventive things, and if he or she wants. He will send you for the mammography, the screening mammography. If some man or individual go for a tobacco cessation, we have a in-house psychologist for the tobacco cessation for there. So we consider we are emphasizing on the preventive things because we are treating fine, but we are now started to screen the family members of the cancer patients. That's why we have started for this. But yes, from you, if you can go from here or say, you are always welcome for this.
On behalf of the SNU NSS committee,
Take the microphone, please, because there is a Facebook live. They won't be able to listen.
thank you for the session primarily. And on behalf of the SNU NSS committee, we would like to proceed with this health camp
Okay.
as one of the primary criteria in this month itself.
Okay.
Talk to the Vice Chancellor, and we will definitely be organizing one health camp.
Absolutely.
Because I think this is one of the most neglected areas as the member secretary, I think this would be really, really good if our students are given the opportunity of faculty, obviously,
Students and faculty.
obviously, but students as well, because they are not very aware like we are. We can say that we are semi-aware, but they are not aware, I think, about
Absolutely.
the problems that are lurking.
Yeah. So how to address this situation for the student mainly? For the breast cancer, the students are around 18 years, 20 years. So no screening tools is not absolute for them. Only the various primary preventive mechanism, the healthy weight, and you have to going to screen at 30 years or 40 years. This education is important now. Not that screening, not that, but here,
Awareness.
awareness. Only the awareness is important from there. Yes, absolutely. But yes, here who are the more than 40 years or having some history of breast cancer in the individual in the family, they have to consider for the mammogram, or in the more than 40 years you have to go for a mammogram yearly. So if that the situation, yes, okay. If you
Sir, I think
service cancer, absolutely, absolutely.
we have to be aware.
So if you like to kind of a liaison with our hospital, then yes, we can talk with our hospital authority, the administrator, regarding how could I send that mammography, or you could go there for this mammogram, whatever, I don't know. So I would really like to talk with my administration. Sure. Fine.
With this, I'll have to talk to the authorities
Fine, absolutely.
I'm glad that this is happening. I'm very much happy. I just have one question. Are you saying, or rather dominantly, that by 60, 65, if the woman doesn't have a breast cancer, that the fear is gone?
No. So I have not talked about the screening. Screening should be stopped for the breast cancer. Screening of the breast cancer should be continued after the US concept or the Western concept is stopped after 75 years. Okay? And in our concept, there is no concept, sorry. So, yes, even in the 68, 70 years, 75 years, we are getting patient from the breast cancer. So,
Percentage-wise, you have
percentage wise, not, I mean, you can say around 5 to 7% of the total breast cancer is more than 65 years.
Oh God.
Yeah,
So there is an
And if
elderly dimension also, elderly
absolutely.
women dimension.
But one thing important, the percentage of those who are aware, really, we got a really small tumors in those individuals more than 65 years. So T1, T2, they have having a kind of a surgery. Even they don't need any kind of chemotherapy also or radiotherapy. Only a hormonal treatment for 5 years is suffice for the individual. Absolutely. So this is absolutely, I mean, good. And we are getting more than 65 years T1, T2 lesion.
I think, Moni, you can do it one thing. Students, teachers, and then, make teachers, research scholar, group-wise. Group-wise, we can, arrange this one because
Maybe we can have a week-long awareness program, and depending on the availability of everybody, they can come and because we can't have
week-long.
that kind of crowd on.
I do not know whether the institute can provide week-long one, but we can try. We can at least we can start the.
We have a very proactive set of teachers who are going to do this. No problem.
Okay, so we will then, because this is a very important area. Kadu, anybody has any other question?
Sir, I have a question.
Oh, sir.
Scientific query.
Yes, sir.
You talked about cervical screening.
Yeah.
Use of acetic acid giving a red coloration. Do we
not
know
red, it's a
what
coloration.
what pigment changes the color because of the pH?
Which?
There must be some pigment over there or some kind of molecule which undergoes that transition because of the lower pH.
So basically, I am not a scientist. I am a typical kind of a barefoot doctor. So I would only say that there is some denaturation of the proteins occurred. So which having a cancer cell, this denaturation ultimately giving kind of a light pinkish color in the cervical epithelium. Okay, so we are kind of things I cannot go deep into.
No, because
even I am not a pathologist.
No,
That's
absolutely.
yeah.
But again, my problem is that I am on the other side.
Yeah,
I do the science only. So essentially, whenever you are talking about, would this be a papillomavirus generated protein or the normal cell protein which gets affected by the papillomavirus?
No, this is the malignant cell. There are some changes in the malignant cells. Okay. And ultimately, when this acetic acid is inserted in the vaginal cervical epithelium, it's denaturation and the change in color only in the malignant cell. But again, I am telling you, sir, the sensitivity is only 65%.
That's quite understandable because, these cells would have what they call major histocompatibility complex, which would be the protein thing, and these are the interaction points. And I'm saying this because there are lots of young faculty over here who would be working as a research tool, and they can really look at this because, even though it is a 65%, it is the first stage of detection that something is changing. So there is enough opportunity because we have a microbiology and biotechnology group and the pharmacy and others who are working in different areas, including Papia. So it would be a good understanding from the university's research point of view that whether something can be done about those things, those areas.
I am telling you the history of the VIA. So history of the VIA is that TMH, that is Tata Memorial Hospital, Mumbai, has started this in the slum called the Dharavi. It is the biggest slum of Mumbai. And this paper was presented in the American Society of Clinical Oncology in 2013 in their plenary session. Okay, so this was a huge effect in all over the world. So so we are always talking about the UK, USA, all the Western, but it is not the world. World is the low socioeconomic person. So So these things, the National Cancer Grid of India, they have suggested the VIA in the low resource setting. So it might be India, it might be Bangladesh, it might be Brazil, it might be Peru. Okay, but yes, so not the HPV. WHO recommended, yes, HPV is there, but that doesn't mean that it is should be in the all over the world.
If you do the first screening and get the number sort of possible suspects and then go to the next leg.
Absolutely.
I mean, it's a question of.
Yeah, obviously, why not?
Just like most of the people do not know that the Warriors was actually invented in West Bengal. That was the first time this was done. And now everybody takes Warriors and everybody understands that Warriors is
Not in West Bengal.
preventive level.
Not in West Bengal, it is by a Bengali in the Bangladesh mainly. Yeah. But yes.
Anybody else?
I just want to know one information that as you described the different stages how to take your breast at home, and if there is no symptoms, still we have to go for mammogram.
More than 40 years you have to. This is recommended. More than 40 you have to go for a mammogram. Yearly mammogram and clinical breast examination by the doctor. Yes.
You mean now more than 65 or 70 also?
Yeah, yes, absolutely. Why not? I mean, there is last part of it. So you have to. Even 80 years I have got a breast cancer patient. 86 years you have got.
I thought at least one case I was,
No,
secure.
but not the cervical cancer. Cervical cancer.
Sir, not sir, but breast, yes.
But breast, yes, not the cervix.
Okay. Hey, take the microphone.
Absolutely.
Gargi.
HRT is a hormone. So, what is that? HRT means that you are taking a estrogen progesterone. So, in the breast cancer, if you can see the total incidence, the 65% of the all breast cancer is the hormone-dependent breast cancer. Okay, so if you are, pushing kind of a thing which you might cause the breast cancer, estrogen and progesterone inside you, it causing increased incidence of the breast cancer in that individual, and it is statistically proven, and there is very high positive correlation of using a HRT and the breast cancer.
Okay, but HRT is recommended for many women.
Yes, but in that case again, I'm not telling that don't take HRT, or someone not telling you can don't take HRT, but you have to go for the any professionals or health professional if any kind of symptoms is present. It is a risk factor. The same with the OCP, that is the oral contraceptive pill. It is a risk factor for the breast cancer. But if someone taking it for the more than 4 years, then it is a positive correlation. But it's not that you should stop taking, or the woman should stop taking. Also not that. If it taking, then you have to go to the doctors. Is there any problem? Is there? You have to go to the doctor. Yeah.
Microphone.
Just one anecdotal experience. After I turned 40 years back, I started going to the gynecologist every year. So then my general physician said, using this language, "Khocha-khochi korar darkar ki." So then I was like, but I thought that I was doing the right thing, right? So as you were saying, as a specialist, we should actually do yearly screening. So, then just as a lay person, should we not get one kind of signal from the medical fraternity?
So this is, really disheartening, rather, I would say. Some general physician is telling that, so this is not the concept, again, of the whole world, or you can say the Western world. They are really ahead of us for this reason only. Because their general physician much more proactive than a kind of a oncologist or something. So this is, this is a learning curve for them. So I couldn't say that you have to do it, but I would say that you have to go a proper place in our country. That I can say. Yes, for obviously the Western, you can go to any physician or the general practitioner, they will consider for this breast screening, but not here, because they don't, here they don't have that knowledge, or they don't have that awareness rather. It's kind of a personal opinion, it's a pre-medication kind of things. So this is not the standardized things, should not be a standardized things. Yes.
Okay, I think we have to let go of Dr. Majumdar. He told us. We thank him profusely, and we expect that he will be associated with us in near future.
Absolutely.
Thank you, Dr. Majumdar.
Thank you for having me. Thank you. Sure.
ম্যাম চেয়ারটা আরে আজকে সাড়ে ছটায় তো আসেন না।
বাসের পেছনে আগে ওর বাসের পেছনে আগে আমি জানতে চাই ডক্টর মজুমদার আসুন তুই পাশে দাঁড়াস না তাহলে তো আমি সব ঝামেলা করছি সবাই তো পাশে ডাকতো আবার আসতে হবে ঠিক আছে সবাই চলে যাচ্ছে কোথায় আমাদের আমি দুজনই স্পিকার আছে তো আসছি না পুরোটা রেখে দিন এইবার তো শীত করছে 22-23 করে দেবো এই 22 বলছি 26 করে দেবো না বাকি তো বলে গেল আসবে এখন বলে গেল চালিয়ে দেবো চালিয়ে দেবো আচ্ছা ঠিক আছে এই হচ্ছে মুশকিল কেউ যোগী ভিক পায় না বলে একটা কথা ছিল মেধো আর মধুসূদন যদি একই লোক হয় তাহলে মেধো বললে কেউ পাতা দেবে না মধুসূদন বললে দেবে নিজের যে জায়গায় আমরা থাকি সবসময় আমরা তাদেরকে সামহাও মনে করি যে টেকেন ফর গ্রান্টেড যখন খুশি শোনা যাবে ও যেন রোজ প্রত্যেক দিনই রেডিয়ে চাই শোনো বলো তো হ্যাঁ এবার গড় করে বলে যাবে এমন একটা ব্যাপার আছে আচ্ছা ঠিক আছে আচ্ছা ঠিক আছে ঋতুপর্ণা এলেন না তো ও তাই বলো তুমি 100 বছর বাঁচবে আমি তো এখন না আমি বলি কোনো মহিলাকে ভারতবর্ষটা বলা উচিত না তার কষ্ট বাড়ে আমি ম্যাক্সিমাম বলতে পারি যতদিন বাঁচো ভালো করে বাঁচো সুস্থ অবস্থায় না ফার্স্ট ভালো ছিল চলে গেছে আর না তো একে দিতে হবে অনেক দিতে হবে সেকেন্ড স্পিকার হচ্ছে দময়ন্তী থার্ড স্পিকার হচ্ছে শ্রেষ্ঠ রাখো কারণ আমাদেরও লাঞ্চ প্যাক লাগবে আমি একসাথে দিয়ে দেবো তোমার লাঞ্চ প্যাক একটা বিশাল বই দেখতে এটাকে ইনোভেশন ধরতে হবে না
behind that. Because cervical cancer vaccination ন বছর থেকে শুরু হওয়ার কারণটাই ওটা, বিফোর দ্য সেক্সুয়াল লাইফ স্টার্টস, but you never know when is the sexual life starting for whom, so there is no like grading that. It's better to start early. It is always better to start early.
আমার কোলনে একটা ডিসপ্লেসিয়া স্টেজে চলে গিয়েছিল, সেটা কাটতে গিয়ে দেখা যায় না, ভর্তি ফাইব্রয়েড, রাখলেই ক্যান্সার, একটা তো আছে কাশি, তারপরে কাটা হওয়ার পরে কি হলো দুটো জিনিস হলো, আইবিএস, আচ্ছা, অ্যালার্জি টু সো মেনি ড্রাগস। ফলে আমার এখন চিকিৎসা করা মানে টাকা ডাক্তার ওষুধ বলবেন না, এটা কিন্তু সাংঘাতিক। আমি এবং আস্তে আস্তে যেটা হলো তাড়াতাড়ি চোখে ক্যাটারেক্ট গ্রো করলাম, 58-এ আমি দুটো চোখে ক্যাটারেক্ট ফলে অনেকগুলো সাইড এফেক্টস হয়, কিন্তু সবসময় যেটা বলা হয় না, কিন্তু বিরাট সাইড এফেক্টস হয়। তুমি ওকে বলবি যে আপনার চেনা জানা কি বলবি, রেফারেন্সটা আপনার চেনা জানা হোক, তাহলে ডাক্তারদের একটা ব্যাপার আছে তো, হোক তো রয়েছে। জলের বোতল,
হ্যাঁ অনেক বোতল হয়ে যাচ্ছে, এটা উনি ফেলে গেছে, সো এটা কি করবো?
কথা বলে জলের বোতল থাকবে, বুঝলাম। জল বেশি অপেক্ষা করলে
আস্তে আস্তে সবাই চলে যাবে।
এই জিনিসগুলো আমার বড্ড কষ্ট হয়। আজকাল আমি না এগুলো অসহ্য হয়ে যাচ্ছি। আর একটু বলেছি অল টাইম, যদি মনে করেন এইটুকু তো আমরা করতেই পারি।
সবচেয়ে বেশি করতে
কাউকে
পারি
জানাই না যে আমরা
to have separate female toilets for faculty members, which is not there in every floor.
আসলে আমাদের দেশে চিঠি লিখলে কর্তৃপক্ষ বেশিরভাগ সময় জবাব দেয় না।
হ্যাঁ, কর্তৃপক্ষ চিন্তা
ওদের কিন্তু রিজেক্ট করলেও জবাবটা দেয়।
হ্যাঁ, not acceptable.
যে কোনো ব্যাপারে ওরা কিন্তু তাড়াতাড়ি উত্তর দেয়।
really we don't have and
দেখো অবস্থা দেখো, এইটা শুনতে চাইছি না, মানে শোনার মতো সেরকম আগ্রহ কোন পুরুষ মানুষের নেই। আর মানে বাকি আমাদের এসএমই তো প্রচুর লেভেল ফ্যাকাল্টি সমান সমান নাকি আমি শুনেছি। হ্যাঁ, অ্যাসিস্ট্যান্ট প্রফেসর নিলে হিমেলিতে নেবে, প্রফেসর না সমান। আমি একমাত্র ব্যতিক্রম, আর বোধ হয় নার্সিং, নার্সিং ওটা অবশ্য কারণ আছে, ফ্যাকাল্টি নার্সিং যা টাকা দেয় অনেক।
অথচ কেউ বুঝবে না, আমি বলবো একটা
টাকা
জিনিস,
দিচ্ছি না কিন্তু বুড়ো বয়সে আছি।
ম্যাডাম আমি একটা জিনিস বলতে চলেছি, যেখানে জেনেটিক্স নিয়ে বলবো তো, যেখানে ওই পার্টিকুলার মিউটেশনটা যদি থাকে, ধরুন কোনো একজন লেডির ছিল ইন দ্য ফ্যামিলি, সেখান থেকে তার ছেলের গেছে, কিন্তু মিউটেশনটা গেছে, ছেলেটির কিন্তু একটি অন্যরকম ক্যান্সার দেখা দিতে পারে, নট নেসেসারিলি ইন দ্যাট টিস্যু যেখানে কিনা মায়ের হয়েছে, মিউটেশনটা আছে কি নেই, দ্যাট ইজ ইম্পর্টেন্ট। এবারে যার ফ্যামিলিতে কোনো লেডি হ্যাজ বিন ডিটেক্টেড উইথ দ্যাট কাইন্ড অফ মিউটেশন, তার জানাটা দরকার, ইরেসপেক্টিভ অফ সে ছেলে না মেয়ে, যে তার কিভাবে সুস্থ থাকতে হবে।
যখন ক্যাম্প হবে
এইটা পুরো গ্যাপ হয়ে যাচ্ছে নলেজটা,
সেই তো অন্তত করবে, কিন্তু আমাদের বাড়ির লোকেরা উইথ অল ডিউ রেসপেক্ট টু অল আওয়ার ফ্যামিলিজ নট দ্যাট কনসিয়াস।
Let's start.
আমি এরকম উইমেন্স ডে অনেক বছর করি, তো এসে নিতে এসে খুঁজছি ফাঁকা হলে, ভর্তি থাকা হলে ভর্তি অভ্যস্ত, শোনা যাচ্ছে না কেন সেই জন্য চিৎকার করে মাইক্রোফোন ছাড়া বলতে অভ্যস্ত। এসে নিয়ে আমাকে ভালোই, জীবনের শেষ বয়সে এরকম একটা, আমি তো কখনো আসলে ব্যাপারটা, আমি তো কখনো প্রাইভেট সংস্থায় কাজ করিনি। আমি তো 28.5 বছর কলকাতা ইউনিভার্সিটি আর 2 বছর বিদ্যাসাগর ইউনিভার্সিটি, ফলে প্রাইভেট ইউনিভার্সিটি কীরকম হয় এটা কিন্তু আমার পক্ষে একটা তোরও প্রাইভেট। ইনফ্যাক্ট যেদিন আমাদের এই বুকটা লঞ্চ হয়, চ্যান্সেলর করেন, সেদিন আমি নিজেই একটু অবাক হয়েছিলাম। বুক তো আমার কখনো লঞ্চ হয়নি, প্রচুর থাকলেও ওই লঞ্চের কোনো ব্যাপার নেই, পাবলিশার বার করে দিই, এখানে লঞ্চ হচ্ছে। শুনে আমি বলেছিলাম যে এইটা আমার পক্ষেও নতুন, আমার বুক লঞ্চ হয়নি কখনো, বুক লিখলেও লঞ্চ হয়নি। সুতরাং ফলে এখানে আমি যেটা কম দরকার সেটা বোধহয় বেশি দরকারই মনে হয়, আর যেটা বেশি দরকার সেটাকে এত কষ্ট করে ছাত্রদেরকে ধরে রাখতে হবে। 10টা 45-এ ঢুকেছে, 4টে 45-এ বেরিয়েছে, কত কষ্ট করে এটা হচ্ছে। আর যদি বলে দেওয়া হয় যে তোমার আসলে আসবে, না আসলে না আসবে না, রেসপন্সিবিলিটি ইজ ইয়োর্স। তুমি কি জন্য যা পড়তে চাইছি, কার করবে কি করে বলো। তোমার কালকে যে লিভ ম্যানেজমেন্ট দেখলাম আমি, কিছুক্ষণ পর থেকে আমার ঘুম পেয়েছিল, বাবা রে। হ্যাঁ, আমি তো সেটা খুব ভালো বুঝেছি, প্রথমেই বুঝেছি। তার কারণ এখানে সমস্ত ধনী ব্যক্তির ছেলেমেয়েরা পড়ে। দেখো, আজকে কিন্তু আমরা বলতে পারবো না যে পুরুষরা আমাদেরকে ফেলেছে, আমাদের তো মহিলারা একদল আছে যারা মহিলাদের দিতে পারে, একটা নিয়ম। আমরা যদিও দময়ন্তীকে চিনি, কিন্তু আমি এত শত জানতাম না দময়ন্তী সম্পর্কে, সেই জন্য দময়ন্তী আমার ক্ষমা করে দিও যদি আমি প্রথমে তোমাকে না বুঝতে পারি।
লজ্জা দেবেন না।
দময়ন্তী সব কথা চাঁদনির সঙ্গে বলেছে, এবার চাঁদনি তার বলে যাচ্ছে, কিন্তু আমি তো রিটেন করছি না, 2% চলে যাচ্ছে তো আমার। তার ফলে দময়ন্তী যে এইটার উপরে আমি বলছি যে কি হবে, কি বলবে ও, পরে আমি বুঝলাম যে কি বলবে ও। ভেরি সরি, অন রেকর্ড। Acha. Dr. Damayanti Das Ghosh has been long involved in basic and transnational research on gynecological cancers. She did her PhD on human immunogenetic factors in in cervical cancers. ও আচ্ছা আচ্ছা, রোটেট, হ্যাঁ মনে হচ্ছে মোবাইলে আর এত পড়তে পারছি না, কষ্ট হয়। এটা তো এভাবে বলছিস তো, আচ্ছা ঠিক আছে, তা তো আমাকে করতে হবে, তবে একটু বেটার, থ্যাংক ইউ। She did her PhD on human immunogenetic factors in cervical cancer caused by human papillomavirus. Cervical cancer is the second most common cancer among Indian women. She did her PhD from the Human Genetics Unit of Indian Statistical Institute and postdoc from University of Pennsylvania. She has been associated as a scientist in research on ovarian cancer and endometrial cancer at Swaraj Gupta Center and Research Institute. where she also directed the Molecular Diagnosis Lab. She has been a member of the International Gynecological Cancer Survey and its Kolkata arm, Kolkata Gynecological Oncology Trails and Translation Research Group. She is presently working in collaboration with SGC NRI, Colgot G ki na TRG training and other organization. She has multiple international publications on gynecological cancer. She has been awarded by International Papillomavirus Society, Global Cancer Consortium, Asian. She has been awarded by International Global Cancer Consortium and Oceania Research Organization on Genital Infection and Nebulosia, Rajiv Gandhi Center for Biotechnology, Indian Society of Human Genetics, Cancer Foundation of India, and other eminent scientific forums. Damayanti, it's all yours. Before that, I would say that I'm sorry that I didn't discover you earlier, because now that I have known, you will have no problem in giving lots of talks. It's all
I'll
yours.
try. I'll dig a little deeper into genetics, but try to make it easy and gradual. So, as my title goes, it is Awareness on Genetics of Gynecological Cancer. And the 5 gynecological cancers that are actually in the reproductive system of a human female. And these are either at ovaries or at cervix or at uterus and then vagina and vulva. Mainly uterus, cervix and ovaries are the predominant ones. And if we see this is also the same page that the previous speaker has shown. Maybe if we could scroll down a little bit in that particular page that he had shown earlier from GCO, that is Cancer Observatory page, the Global Cancer Observatory page, we can see the Indian cancer statistics as well, including both males and females. And in the very first page, we can see across all different cancers, these 3 are very much present: cervix, ovary, and endometrium, all 3 being in the reproductive system and so-called gynecological cancers. In the Indian female cancer statistics, now concentrating only in the female cancer statistics, this slide was already shown, this particular figure, which is from Globocan 2022, and this is maintained by International Agency for Research on Cancer, which is a WHO arm. And we can see it has already been discussed that cervix uteri, that is the cancer of cervix, comes second to breast cancer and third stands ovary. But few years back in 2012, it was a different story where cervix was higher and then breast was in the second position. But gradually the scenario has changed, maybe with awareness. But now, how if we go ahead? Now this page is also available. If we search in IARC, that is International Agency for Research, the one that I was just telling, Globocan, we can also get this, the projection till 2050. And if we compare a very developed continent with ours, our country, and a very developed continent having the most developed countries, we can see that strangely now, this is the incidence rate, that is the new cases coming up every year, the blue one, and the red one is the mortality rate, that is how many are dying every year. So we can see that we are here, it is 2022, so it's running, this is what is still being followed. As yet, the next one has not come up. This is Globocan 2022 is still running. So from 2022 onwards till 2050, if we see the earlier version, we can see that we are actually having a lower incidence of cancer than them. That is, the cancer is not that much occurring as a new case every year, okay, in our country. compared to the most developed countries. But if we project it, we see that the curve is actually shooting up in our case, but in their case, it is kind of controlled, right? Even in case of mortality. So they are getting it controlled. And I find, as I read through the literature and also during my research days, what I have seen that the two major factors are the late detection due to lack of screening and genetic counseling. And also, as we go ahead in research, we know how genetics is having an impact on every kind of therapy and every kind of diagnosis in cancer. So unavailability or unawareness of the possible precision treatment due to genetics is also there. So now I come to the role of genetics in this. So it has a role in screening, in precision treatment, in genetic counseling. In screening, we are actually looking into what we call normal individuals, or maybe they are asymptomatic individuals. Those they have not yet gone to the doctors because there are no symptoms. But the most important thing over here is that screening is important because even if these are asymptomatic, before the symptoms arise, there might be some signature available. If that could be taken up, if that could be found. So screening is important. And once it is found, then whether precision treatment would be given to those patients. And the kin of the patients, that is the blood relations, they need to be counseled even better that what they do have in their genetic profile. So both increased screening, all the three, treatment plan and family screening, are important, and genetics have a role in this. Now, one by one, I would focus in the context of genetics on the different, the three most frequent cancers, the gynecological cancers, of which, of course, cervix comes first, ovaries are the next, and uterus is still not that much into the scene, but it is on the high in the low and middle income countries. It is actually still in the high income countries, it is the most eminent gynecological cancer. But in case of low middle income countries, it's not yet so. But because you know that the scenario has changed in case of breast cancers, which was actually low into 2012 compared to the developed countries. Now it has become the #1 cancer in India also. So we never know what is there in the fate of uterine cancers also. So we need to be aware about uterine cancer
I
also.
cannot hold myself to intervene because, all feminist research, which are not read, specifically in India, we're afraid of the word feminism. Somebody feminist means almost untouchable. So there's a thesis on behalf of development feminists that as we otherwise go ahead, women's health deteriorates. Because what women used to do 200 years back, now it has been fourfold. And the body cannot take it. And the rate of heart attack has surpassed men. Previously, it was told that women do not have hearts, so they don't have heart attack. Now, women have more hearts than men, so they are dying also in that.
So the frequencies and the statistics keep changing. They are evolving. So we need to know the impending danger also. So I chose these three cancers. So cervix, I will come first. It has been already elaborately told by our previous speaker. Just this one slide I want to put up over here to show you that how this infection goes in. So this is the viral DNA. So this is the virus, if you follow the cursor. And this is the DNA inside, rolled in a coil. This moves into the cell. So whenever there is a sexual contact with an infected person, the virus gets deposited here just on the cervix. So this part is the cervix, just the end of the uterus. The terminal end of the uterus is the cervix. So here, the virus gets deposited into the cells. And if there are abrasions in the skin, which could be due to multiparity also, because many of our rural women, they have suffered cervical cancer and they have suffered multiparity also. So multiparity is multiple childbirth, okay, multiple children. And so what happens, this cervix is not intact, it has gone through wear and tear, and so there are abrasions, there are cuts and abrasions and wounds. And what happens, the virus actually goes through these wounds and gets lodged into the basement cell, the lowermost cell, which is actually proliferating. Otherwise, the other cells are generally not proliferating. They have reached their terminal level of proliferation, but the basement cells are still proliferating, and it goes into that cell and gets a home there. Now it starts proliferating. Now the basement cell is proliferating and it's coming up, but it's still not cancer. It's still not cancer. So there is a huge time. So there is a scope of screening, because you can see here it's written 10 to 30 years. 10 years to 30 years from the time the virus infects this particular epithelial layer, we can call it, and till cancer happens. What is cancer? All these cells are now cancerous, so they are now breaching this basement membrane and they are invading into blood and the tissue even deeper inside. Okay? So it is invading into the system. So this is what we call invasive cancer. But this takes so long in case of cervical cancer. And it has a viral etiology. So we can screen. And this is actually the slide which was made by the person Annika Roll. I have written her name over here for the Nobel Assembly in the Karolinska Institute, because in 2008, because this was the reason why Dr. Harald Zurhausen was given the Nobel Prize for identifying HPV DNA from these isolates of cells. From the cervical cancer cells, and we can see this HPV is there. These are the HPV different, this is a particular PCR, a particular tool you may say in genetics, by which we actually can find a piece of DNA. Okay, that may be a human DNA, or that may be a viral DNA, that may be any DNA. So we can find this DNA out by this tool. So here you can see it is written positive, 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 and this is negative. So these three samples are positive for the HPV viral DNA, but this is not. And this was why Harald Zurhausen got the Nobel Prize. So the screening methods are definitely, for this case, not only pap smear. Pap smear is it will look into the cells. It will take a smear of the cervix with a spatula and spread it on a slide, and will show you the cells, how the host cells look. But it is also important to find out the gene of the HPV in that smear. So it is HPV DNA or gene testing, which is very much important in this case, because not all HPV will ultimately lead to cancer. Only the oncogenic HPVs will make it cancerous. The majority of the HPVs, even the oncogenic ones, are actually, you see it's written over here, 90% heal within 2 years. So they are spontaneously cleared. So that's a natural viral life cycle that's happening. They're being spontaneously cleared. But only in those ill-fortuned ones, they get inserted. The HPV DNA has got inserted within the host DNA, that is the person's DNA whom it has infected. So now all these cells are no more only the human DNA, they are having also the HPV DNA inserted into it. Now all these cells are now becoming cancerous. Only 0.8% develop cancer, but still then it is so high in case of Indian scenario, because we are seeing that till 2012 it was the major cancer among women, and now it is the second major cancer among women. So there is a huge scope of screening for this viral DNA and the particular type of the viral DNA. Even if HPV is present, what kind of HPV is present is important to be noted. That's a paper of mine. I just thought of projecting over here because other than the viral factors, there can be also the host factors. Sir was asking about the major histocompatibility complex last time, but he's not here now in my talk. So this is major histocompatibility complex, HLA class 1. So HLA, which is human leukocyte antigen, which is also known as major histocompatibility antigens, and here they also do have association with in the cancer, in the cervical cancer pathogenesis. So not only the viral factors, but also host factors. Why few of the hosts are actually letting the HPV to be persistent and why the others are not. Those 0.8% who are actually letting them to be persistent are actually moving into the cancerous part. The others are clearing them. So it must be a host factor also. So it is a topic of research, and I'm here to give you that that glimpse into the research and the genetic research that can be done on the basis of this. So now these are the...
Can you just tell us the age group relating to this cervical cancer?
So this is like, in this case, you can see some, it is very important to understand it starts with a sexual contact. So the person has to, that's why the idea of 9 to 14, okay, you catch them early. Because before this HPV has got into the system, you catch them early and create some antibodies in the milieu so that they can fight the virus out.
Okay.
Once it is inserted, it is difficult, okay, because it's not a therapeutic vaccine, it's a preventive vaccine. So it has to be caught early. And then from, say, the earliest sexual contact till 30 years down the line it takes to develop into cancer. Okay, so now here, that was the part of screening. Similarly, I would also just give you a glimpse of the scope of precision treatment over here, though it's still under research. So this is the Cancer Genome Atlas data, which is a hugely popular database for cancer geneticists over the world, and it's hugely helpful and resourceful for all the cancer geneticists. So here we can see the different genes, and this thing, what I have mentioned over here, is this cancer is heterogeneous. Because not all the females are having the similar kind of mutations. They are having a variety among mutations in them. Some of them are having this particular gene, PIK3CA, which is very highly frequent. Okay, some highest, the highest frequency is of PIK3CA, and there are trials also. The drug against this PIK3CA PTEN pathway has been in the trial. So different patients can have different mutations, and the mutation-specific targeted therapy, if available, can be opted for following doctor's recommendations, of course. But this is an awareness talk that we are talking about, and I just thought of mentioning this possibility of seeking whether there are any mutation and whether there are any targeted therapy available for that mutation once the cancer sets in. Now next. With that, I would shift my gears to ovarian cancer, and these do not have any viral etiology. Not published, at least much. So mainly genetic mutations of the person are associated. But then I am telling it from the aspect of genetics, I being a genetic researcher. But then cancer has always been told as a complex disorder. So there are complex disease. So there are variety of things that are happening, not only genes, also environment, nutrition. So this is the genetic part and the awareness about that I want to give you. In case of ovarian cancer, there can be heritable mutations. So this is a strange graph because you can see almost 90% of the patients have shown mutation in a particular gene. Even after being so much heterogeneous, at least P53, this is the gene which has been found in more than 90% of the cases, at least in this cohort, that is this group of patients whom this particular database opted for. And this is the most popular database, I can tell you. But then there are no drugs yet against P53. It's a tumor suppressor gene. So P53 is actually called the guardian of the genome. So if it is okay, we are okay. So it suppresses tumors. It actually keeps the cells okay, keeps the cells functional, it keeps them going, and whenever it detects any problem, it stops the cell. It stops the cell and it drives it towards apoptosis, that is cell death, by natural way. But if it is mutated, then that natural clearance is gone, or the natural vigilance is gone. And so the cell, even with mutation, even with all its problems, it keeps going on and proliferating and turns into a cancerous cell. But then there are no drugs yet. There are researches going on. But then BRCA1, BRCA1, the one that the previous speaker has also told about, has a therapy associated with it. There are resistances to that therapy also. But then first-line therapy is available for BRCA. So if there are heritable germline mutations, then the asymptomatic blood relatives should be counseled and the follow-up is necessary. Why? Because this can help early detection and better treatment. So from here we move into two parts of it. One is the genetic counseling part, where the relatives come in, the blood relations come in, and the other is the patient herself, who is suffering from this, can be treated better. So first I will move into the susceptibility genes and the genetic counseling part. So
can I just ask a question?
Yeah.
I'm sorry,
Yeah, sure.
But if a person is alone, doesn't know who she or he may be adopted or orphan, what happens then?
No, that is not connected at all. I mean, she will lose the line then. So she has nobody to say that if I have that particular mutation, you may also have the mutation. That connection is gone.
Right.
So it is because it is heritable. So there is this difference between being genetic and being herited. Okay. Anything that is a disease that is coming from genes, or anything that we talk about genes, that's genetic. Okay? That need not be herited. Herited means it has to be coming from the parents, okay? Or in the bloodline, it has to be there. And we are talking about heritable, hereditary ovarian syndrome now, where these many genes are associated, have been found to be associated. If these genes are found in that patient, then her nearest kin or her blood relations, they absolutely need a genetic counseling and a further detection. Even if they are asymptomatic, they need a detection to find out whether they are also having this genetic mutation or not, even if they are asymptomatic. Because if they do have, like in case of Angelina Jolie, if they do have that mutation, there is a huge chance that they will be having those cancers in later half of their, or later in their life. So they need to be told. First of all, they need to be told, made aware of, and then properly followed up. Till there is cancer. So that cancer, if detected, as the last speaker, who also a doctor, he said from himself that if cancer is detected in stages 1 and 2, the earliest detection we can do, the better treatment, and even it can be cured. So that's why the very moment you know that the person, even no symptom, nothing, but having the mutation, keep tracking him or her. This particular mutation can also move into the males. And males do have breast cancers also. So this particular mutation, BRCA1 and 2, they are also associated with the breast cancers. So this is called in general a breast ovary disease. Both breast and ovary cancers can be affected because of these mutations. And there are other genes also. I'm not going into that depth. Yes,
if a
ma'am.
person is having both cancers,
Yes.
what is their life expectancy?
That too, if it is early caught, then it is very high. Yes, the doctors can say even better. But then it has to be within the stage 1 or stage 2, because they will be operated.
So identification of this is very important.
Yes, because after a particular stage, they will go directly for palliation therapy. No operation can be
Because
done.
India lacks completely prevention system.
Yes, that is why this
Whole
screening
policies has been on
treatment
just cure.
on
no
cure.
Prevention, no prevention.
Yeah.
Cure, that is also not sustainable.
Yeah.
So this is a major defect in the health policy.
Yes, and that too now with the genetic impact that we are seeing, we as researchers, we are seeing that even the treatment shouldn't be uniform actually. The treatment can vary. It should be more personalized treatment. The person with having a particular mutation, if a targeted therapy is present for that mutation, go for it. If not, don't give that particular therapy to the person, because even therapy overdose can kill. So this is a genetic counseling session, and I will also talk about the uterine endometrial cancer. And these are actually these ribbons have different colors for all the different gynecological cancers. This teal ribbon is for ovarian cancer, and this peach color is for uterine cancer. Both of them have a hereditary handle to them. Okay. So this was one of the genetics counseling sessions. It was like a workshop session. One of the nurses are carrying on, and I am grateful to our nursing department for collaborating with us for making this happen. Thank you, Madhavi ma'am. You were sitting over here. It was a long talk with Madhavi madam and Nyoti madam before we could make it possible.
I think,
the clinic.
The clinic should be regular because nursing,
Yes.
full staff there, and health
We are
sciences
trying.
there. So we should run free of charge a clinic, not only for the university, but also for people surrounding area.
Yeah.
Because there is a
That can
very
be planned.
quite poor surrounding area in the Finch. We should not be, hoaxed by the big buildings which are going up.
Right.
Just over there, there is a huge area. Because this would help in terms of what to do.
Yeah, so this was done in collaboration with Colgo TRG. As you know that I am a member of that also. Founder of Colgo TRG, Dr. Oshima Mukhopadhyay, is sitting just right there. She is has been an eminent gynae oncologist. She practices outside, and she came that time. She lives in UK, but then she came that time, and she also was present very much. And the person who is delivering the talk over here is a nurse, and is delivering the talk to our nursing students about how this genetic counseling goes on and is applicable in for hereditary breast ovary cancers. Next, the scope of treatment. So this was about screening and counseling. Now about treatment. That I said that BRCA is very important. If it is present, then that person can be given the particular treatment. It has been discovered. For other, as I told, P53 mutation is so much present, almost in 90%, but there is no drug yet. But for BRCA, there is a drug. So there are PARP inhibitors. They come in different names like olaparib, rucaparib, and niraparib. I have not gone into so much detail, but these PARP inhibitors, what they do, if this is a DNA, they will just, this generally, if there is, they work in together with the regular treatment like chemotherapy or radiotherapy, whatever is given. With chemotherapy especially, if chemotherapy is given, this DNA gets broken. And if this BRCA is deficient, if BRCA is mutated, that is, it is not present there, then that DNA, this one in this case, if this is deficient, tumor cell with BRCA1 or 2 negative, okay, negative, so it's deficient. In that case, this cell will not be able to repair its DNA due to those chemotherapeutic drugs. So chemotherapy damages the DNA and tries to kill the cancer cell. So this is the cancer cell, and it is the DNA within the cancer cell. Chemotherapy tries to kill it. But what happens? BRCA helps in repairing. So if BRCA is present, it will repair Here it happens. These are all positive. Or even if it is positive in a single copy, it will repair. And the cell, this cell is a cancer cell. It will survive. So there is resistance to the chemotherapy because the cell survives. But luckily, if that lady also has a BRCA mutation, right? So BRCA is now negative because it is mutated. So it can no more repair the DNA. So the DNA damage is there because of chemotherapy. At the same time, you are giving another PARP inhibitor, that is another drug which actually helps in DNA damage. PARP helps in DNA repair and the inhibitor helps in DNA damage. So both of them together is what is called a synthetic lethality. Both of them together kills the cell. So the cancer cell, this cell death is the cancer cell death. Okay? So this is possible in case of BRCA as of now, which is not present in all the ovarian cancers. Okay? It is present in a few percentage of the ovarian cancers, but those who are having BRCA can get this therapy. Okay? But those who are not having BRCA, for them it is useless.
Damayanti, do you know whether these are taught in SNU syllabuses?
No.
You are the one to ask for it.
Yeah, I can.
Syllabus depends on the particular group of, syllabus depends on the particular group of teachers present at that time. I'll just tell a very personal anecdote, very short. When I joined University of Calcutta at 1989, and then we had a departmental meeting to see what I can teach. And when I looked at the syllabus, spontaneously it came out from me. This seems just when I was born, that up to that time. And I made a mistake. So all other senior professors got mad. I said, I didn't mean that, but kintu syllabus ta to update korte hobe. Tokhon bola holo, jara amra ekhane achi, those who are here, we are comfortable with this syllabus. Then I said, what does it mean? It means it stays as it is. So আমি বললাম যে it will be a resolution in the departmental committee meeting? No. তাহলে কি? তোমাকে এটাই পড়াতে হবে। আমি বললাম আমি যদি এটা না পড়াই বা অল্প পড়াই হবে না। আচ্ছা। I said yes. 2 days after, I went to the Vice Chancellor, one of the most erratic Vice Chancellor of Calcutta University, Bhaskar Rai Chaudhuri, the famous doctor. But I explained the situation to him and said, suppose this happens in your subject, what will do? He thought about it, said, I'll look into it. You submit me an alternative syllabus. I did that. He called and at time, 1989, full-fledged left front. Right from your janitorial service to the professor. Everybody is left. And I'm not neither left nor right, nothing. I'm the orphan. Because I didn't do things from Calcutta, the PhD, etc. But Bhaskar Rajati, to everybody's utmost surprise or shock, that he agreed. He told that nobody told me that these are the developments in sociology. So I didn't know. Now that somebody told me, you tell me that these are not correct. And from then on, I made my faith in Calcutta that I will be always cornered and pushed. I took that though. But that's why I asked in SNU syllabus. কারণ এখানে syllabus change মানে আফিল হওয়ার কথা। যে যা পড়েছে তার বাইরে একটুও পড়বো না, যে যা পড়ে এসছি তার বাইরে। এটা যদি হয় তাহলে সেই 89-এর কলকাতায় আছে, কিন্তু কলকাতা নেই আর, কিন্তু 89-এ কলকাতায় গিয়ে গেছে। ফলে এইটা আমি younger generation of teachers যারা directly involved in teaching, I'm just praying to you that please do not be scared to say what is necessary to be taught.
There is a part on medical genetics.
Yeah.
But then how deep it goes and how much is related or how much is required, that needs to be...
If it is required in any way, you can have, don't have to have full course, but modules. Nowadays we have modules which you didn't have earlier. So it can be done. It must be modernized, so to speak, and not try to differentiate, this is an economic problem, this is social. There is no such thing in reality. So we have to be understanding problems. In 19th century, one German philosopher said that we have to understand the problems, not the disciplines. We don't study disciplines, we study problems. That means we have to cure that. So did Rabindranath. Go ahead, I'm sorry.
Thank you, ma'am, for your insights.
Interesting.
You're most welcome. Next, yeah, so this is the last part where we are coming to the uterine one, which we also call endometrial cancer. This is the inside layer of the uterus, okay, high up from cervix. Now, here another important thing is the Lynch syndrome. What is that? These genes here in the lower panel I have shown, these are the genes. These are the, say, 4 genes which if mutated, then there can be a Lynch syndrome. And what is that? Because of Lynch syndrome, there can be multiple types of cancer, and there the lifetime cancer risk increases. Okay? So, and this Lynch syndrome is actually an autosomal dominant one, that is, it will pass and will show. If it is recessive, it will pass, but it will not show. But if it is autosomal dominant, it will pass and it will show in the progeny, either from the father or from the mother, whoever is affected. And here, that's why I was telling in that time that if the mother is affected, it will go to the son also. In the son, maybe it will not come up as ovarian cancer, but will come up as the colorectal cancer. Right? So there is almost an 80% chance of having colorectal cancers in the persons who are having Lynch syndrome. There is a 60% chance of having ovarian cancer, and lower than that is, 60% chance for endometrial cancer, lower than that is ovarian cancer, and even lower is stomach cancer. But they can, and in our cases, these percentages, the actual counts become huge, right? And scope of precision, again, there are different genes, and cancer is heterogeneous, and as we know, and there has been a revolutionary paper in Nature where they have shown, particularly in endometrial cancer. So this is a survival curve. Okay, we call it a survival curve or a Kaplan-Meier curve. I'll just give you the very a little glimpse about it, that this is the best survival, the one that goes straight. That is, 100% of them are surviving. Doesn't matter how long you pull them. At least till 100 months, yeah. At least till 100 months, they are surviving. Okay? So this is the best survival group. And this is the worst survival group, the red one. Okay? Because by the 80th month, they have crossed 50% survival chances. Okay? So this is the best one and this is the worst one. Both of them are endometrial cancer. The only difference in them is their genetic profile, is their mutational profile. So the one who can survive better, they don't need a harsh treatment. So now we are talking about avoiding over-treatment or under-treatment. So this is what is called precision treatment. Those who are having these mutations should need a radical treatment. So I have also contributed a little bit in here about the poly-like other favorable mutations. The one that was in blue was having a mutation in polygenes. So now let's wrap up. So we have seen there can be somatic mutations and there can be germline mutations. So as I was telling, so genetic mutation or hereditary. So this is the germline that comes through the blood. So this is hereditary. That can be screened because it's present from the very birth. But this cannot be screened once. This may not be screened once by one chance. It may need repetitive screening. Okay? Both of them, if screened, will be detected early and will have a better treatment management and will have a higher survival chance. Okay? But because there can be a requirement of repetitive screening, these screening methodologies need to be non-invasive. So I just want to give you a concept about liquid biopsy, where just by taking blood, different, instead of the standard tissue biopsy, which is quite invasive because that is the biopsy that we know about, right? Cutting the tissue out. But in case of liquid biopsy, you are just getting the peripheral blood, which can be done in an OPD, in any OPD. So here, so how many analytes? There are so many information available in the blood. There are the blood cells itself, there are DNA also from the tumor. These DNA have come up and mixed in the blood, okay? And there are tumor cells also. If the cancer has progressed much, then we will also get circulating cancer cells here in the blood, because they are metastasizing through the blood. So this is a resource of information on molecular signatures, and there is active research going on this, and has a huge potential to be extremely useful in screening and early detection, but it's not yet well standardized other than lung cancer, okay? In lung cancer, which is standardized, they catch EGFR mutation through that and they give a particular targeted therapy, but in ovarian or in gynae cancers, it's not yet, but research is on. So we sum up the essential roles of genetics for all these three cancers in screening and in precision treatment. With that, I end my talk. I have to acknowledge the various my collaborators and my teachers and mentors and the collaborating institutes from where I have been able to do my research and still am collaborating. So thank you on the eve of International Women's Day, and let's stay aware.
May I ask you this? Could we have an interdisciplinary 2-day faculty development course on the role of genetics with the complex relationship with social forces? Because when we go to the doctor, we study the body that time. It's a positivistic position. But how it developed, what kind of circumstances the person lived, we hardly talk about it. But the whole thing is related there. So we are cutting it out and making it silos, that as if genetic has nothing to do with how you live your life. Can we have that?
Yeah, definitely. At least the awareness. I think the awareness needs to be there.
For awareness generation, social and genetic. Can we have a 2-day course on that?
How do you want us to be
help us so that we can make... See, my task at the moment is to do as many interdisciplinary things possible, because the future line of all universities is now interdisciplinary. You won't survive 10 years from there now. So that way, if we can give... Suppose we cannot give it in degree forms because we don't have that infrastructure, etc. But at least we can do short programs, interdisciplinary, so that people from every walks come and also give basic things. We don't talk, completely specialist things, but basic things, which are very important for everyday life. Because social sciences is now on everyday life. How every day we actually give it. So when I go to the doctor, I didn't say, look, I had this, I'm this, I had this. Neither doctors also asks. Only very conscientious doctors ask that, what are the medicine you have, etc. So that we can start that awareness, because other than medical school, there are no university in India does that. It's a peculiar scenario. All universities in India, mostly 95%, are running on 20th century mid situation. I can graduate some of them to 20th century last decade. But since 20th century last decade, it's called globalization of everything. Even the globalization of virus, lockdown. Yeah. So obviously we get updated. আমি সেই 1990 সালের এটাই বলছি, বার করা উচিত যেটা বলেছিলাম। Sir, we have to be updated. After all, it is Calcutta University. এখন আর সেটা বলছি না, এখন বলছি at the age of 71, we got to still get updated until our last breath permits. So I'll request my younger colleagues to help me and the center, me and Chandni, the center, so that we can really do something. এখন তো আর আমাকে ছাত্র পড়াতে হচ্ছে না, এটা একটা অ্যাডভান্টেজ আছে। কারণ তো ওই লিভ সিস্টেমে আমি একদিনও টিকবো না। আমি এসব বিলিভ করি না সারা জীবনে, করতে টিকবো না। আমি সবাইকে দিয়ে দেবো, আসুক না আসুক, কী আছে না। ফলে ব্যাপারটা হচ্ছে যে লেট আস ডু সামথিং কনস্ট্রাকটিভ ইনস্টেড অফ পানিশিং ওয়ান। ইউনো মানে আইভান ইলিচ বলে এক সোশিওলজিস্ট ছিলেন, তিনি লিখেছিলেন ডিসকুলিং সোসাইটি। ওটা আমি যেখানে ছিলাম সেখানে টেক্সট ছিল সোশিওলজি হেলথে, ডিসকুলিং সোসাইটি। তারপরে ব্রেক দি হেলথ সিস্টেম। আমি একটা র্যাডিক্যাল স্কুলে সেই সময় ছিলাম খুব বেশি রকম, মানে যখন এম এ পিএইচডি করেছি সোশিওলজিতে। ফলে আমি দেখতাম যে ওরা কীরকমভাবে ওপেন করে দিচ্ছে সিচুয়েশনটা। ইসেনির কেউ মাথা ব্যথা করবে না আমরা এগুলো করলে, কিন্তু লেট আস ডু ইট। খুব একটা পলিসি আমি জানি না প্রফেসর বোস কী করবেন, হি ইজ মাচ ওপেন। আমাদের 18 তারিখে যে মিটিং আমি মানে হোপিং ফর ইট, তার কারণ হচ্ছে যে লম্বা লম্বা দাঁড়গুলো করেছি না, পলিটিক্যাল সায়েন্স, হিস্ট্রি, বায়োটেকনোলজি, সবাই কাকে নিয়ে? মানুষকে নিয়েই তো, আমাদের নিয়েই তো, সমাজ নিয়ে তো। সমাজবাদ দিয়ে তো কিছু হবে না, সমাজ মানে কি? লোকগুলো। ফলে আমি তোমাদের কাছে রিকোয়েস্ট করলাম পার্সোনালি যে তোমরা আমার সঙ্গে হেল্প করো এগুলো যাতে আমরা করতে পারি। পাপিয়া ওকে, আর ও আমাদের নেক্সট স্পিকার তো বুঝেই গেছে কী করতে হবে। আচ্ছা, দমন দিকে প্রশ্ন থাকলে খুব চটপট।
I think the genetic testing, how far it is done, like screening wise from the newborn, can we get that genetic testing done or maintain a data regarding that?
No, how many times will you do it? That is important.
If it's in the germ line, then I think we
yes,
can.
that can be done. That you.
But how aware are we? Like,
No, we are
are we
not.
doing that or something?
We are not
Genetic
aware.
counseling, as I know, in cases of miscarriages and things like that, this genetic counseling or genetic
Yeah.
testing has come up a great part.
But
So,
for cancer, it is not.
so is there any initiative taken into that?
We are. I mean, we have our own pockets, right? So we have not yet kind of held all the hands that are present, maybe in nearest vicinity also. We need to hold the hands and make it a larger community so that it can be spread.
Can
in
we
the
make it
form of
a
awareness first,
yes, not only
and then-
awareness, like in the policy making, like we can make it mandatory for the newborns if that is possible or not.
Now, only if it is running in the family.
In the
yes,
family
yes,
line, in the
that will be very, I think, progressive.
Nowadays
Yeah.
they do it for diabetes. Just to, as soon as there is a newborn, if there's a thing running in, if there's any hereditary history of having diabetes mellitus or type 1 diabetes, they do it for the kid. But this kind of thing is not heard of, that they're taking care of genetic screening for newborn.
For cancer.
Even if, for cancer, even if they have it in their hereditary up somewhere.
That's why I showed you in the first graph that I showed. In Northern America, they will control it. But we are lacking behind in two things.
We are lagging
are
behind
not understanding
by-
genetics. We are thinking as a whole body,
The
maybe.
reason I think is the prejudice which was created in the early 20th century by Hitler. That's a real fear which casts shadow on the fact that genetic research means discrimination, which America also practiced until 1970. When Vietnam War was over, people started to come to North America. They were given absolutely separate position. So there is a huge racist position still in existence, though we are not admitting it. But America is still the champion of kind of racism. Trump offered to give citizenship if you give $5 trillion. So what does it mean? Who can give $5 billion? So obviously they are still racist and this exists. So that's the fear with genetic research. কারণ আমেরিকাতে একদল সায়েন্টিস্ট পোস্ট 1960s বলেই দিল যে চাইনিজ আর ভিয়েতনামিজদের নাকি ব্রেইন ছোট আর কালোদের ব্রেইন খুব সামান্যই আছে বডিতে। হ্যাঁ, এটা 60s রিসার্চে বলেছে। হ্যাঁ, তার ফলে সাংঘাতিক রিপারকেশন হয় এবং অ্যাকচুয়ালি ভালো হয় একদিক দিয়ে, যে ওটা যে মিথ্যে সেটা প্রমাণ হয়। সো দ্যাটস ভেরি ইম্পর্টেন্ট। আমাদের কিন্তু এখনও ধারণা আছে কিছু কিছু, ভালো বাড়ির ছেলে ভালো বাড়ির মেয়ে, বড় বাড়ির ছেলে বড় বাড়ির মেয়ে। কে রে ভাই, তাজমহলের মেয়ে ছেলে কে? ভাইটা কে এখানে? হু ইজ দ্য কালপ্রিট?
না ম্যাম, ব্রেন ছোট না বড় নিয়ে প্রবলেম থাকতে পারে, কারোর হয়তো গায়ে লাগতে পারে, কিন্তু রোগ, ডিজিজ, when it comes to disease and death,
না না, ও তো
সেটা
ওইভাবে ভাবছে
সকলের-
না, আমরা তো বলি ক্লাস ওয়াইজ, হ্যাঁ, ও তো ওভাবে ভাবছে না।
সেইটাকে যদি আটকাতে হয় আমাদের,
আটকাতে গেলে একটা
যে
সাউন্ড পলিসি
ডিজিজ নিয়ে জানতে হবে।
একটা সাউন্ড পলিসি লাগবে। আমাদের কোনো সাউন্ড কোনো ব্যাপারে পলিসি নেই, হেলথ কিছু নেই, উইমেন্স পলিসি ডিগবাজি খায় পলিটিক্যালের সঙ্গে। এখন আমরা সীতা মাহাত্মে চলছি, কিছুদিন আগে অন্য লোকের মাহাত্মে ছিলেন, এভাবে তো চালাচ্ছি আমরা। আমাদের ইন্ডিপেন্ডেন্ট উইমেন্স ইস্যুস নেই, আমরা হ্যাঁ চলে গেছে একদম ইন্ডিপেন্ডেন্ট উইমেন। হ্যাঁ, আমরা হয় হয় সীতা, নয় কি বলে না ওই যে ক্লারা জ্যাটকিন, এরকম কিছু, মানে লেফটিস্ট কিছু, আর নয়তো রাইটিস্ট কিছু। এছাড়া আমরা তো কিছু নই, আমরা নিজেরা কিছু না। প্রত্যেকটা পলিটিক্যাল পার্টির একটা উইমেন থিং আছে, প্রত্যেকটা পলিটিক্যাল পার্টি। কেন আছে? ভোট। এখন ভীষণভাবে দুর্গা হঠাৎ অ্যাপিয়ার করছে। আমি ওপরেও শুনলাম একটা কবিতা দুর্গা সম্বন্ধে এবং শক্তি সম্বন্ধে। এখানেই একটা মজার কথা কেউ বলে গেল না, সেই দুর্গা পিটুনি খায় 100%, ইন্ডিয়া 1, 2, 3 আছে ডোমেস্টিক ভায়োলেন্স। ফলে এই আর কি আমাদের, আমি মনে করি অ্যাজ টিচিং পারসনস উই শুড বি ওপেন এনাফ টু গিভ সাম ধাক্কা। We don't have to be all trailblazers, but we can give some push so that the universities start thinking. কারণ আমি আবার সেই পার্সোনাল অ্যানেকডোতে যাচ্ছি। এই ডিপার্টমেন্ট সেন্টারটা যখন স্থাপিত হয়, এটা কিন্তু প্রফেসর অশোক ঠাকুরের আইডিয়া ফ্রম দ্য বিগিনিং। এটা যখন মানে হলো, তখন যারা আমাকে তাড়াতে চেয়েছিল ফ্রম দিস ইউনিভার্সিটি, কেননা আমি ছাত্রদের সাজেশন দেই না, নোট দেই না, প্রশ্ন বলি না, তো ফলে যারা তাড়াতে চেয়েছিল তারা ভেবেছিল ওই যে 2x2 প্রাসাদটা আমাকে দিয়েছে একা, তখন আমি চাঁদনি আসেনি, ফলে ঠিক হবে। কিন্তু আমি ওই 2x2 থেকে একটা মারাত্মক মনে মনে প্রতিজ্ঞা করেছিলাম, এই 2x2 2 বছর পরে তোমাদের মুখে এক ডট। And now everybody wants to have association with some of that people want, because they have understood that we are not here to create nasty things.
Ma'am, let's do the 2-day short course as you suggested. This is out of my personal interest also. I have an interest in cancer, and it was such a coincidence that I met Dr. Rajkot while doing in-meditation. And then we
It's a fruitful, productive introduction. Acha.
Let's go ahead with the 2-day short course.
But then before I go to your question, I just want to tell Madam who asked me the last question that there are few cells, I mean there are few organizations and the diagnostic labs, they do have counseling available with them, but not all. In fact, majorly it's not there, but few of the very updated ones, they are having counseling, also side-by-side detection. Yeah. I'll go to the next question.
Very insightful session. Thank you for that.
Present.
ম্যাম, আমি একটা খুব জেনারেলাইজড একটা আইডিয়া পেতে চাইছি অ্যাবাউট ক্যান্সার বিইং হেরিডিটারি। হাউ মাচ ক্যান্সার ইজ হেরিডিটারি? নট
Absolutely. So even the last speaker has given this proportion. So you can have hereditary cancers, even, I mean, the germline cancer and the mutations and the somatic mutations, both are similar mutation, just where they are happening. That is what is important, at what phase of life it is happening, right? So there is, definitely there are around more than 10% chances that it will be a germline cancer, okay? But then it depends on the cancer, okay? So which type of cancer you are looking into, and in our scenario, given the population, even 10% is a huge number, right?
Yes, definitely.
So whenever the cancers that are known to have a genetic, I mean a hereditary association, those cancers at least need to be tested for genes, for mutations. And if the mutation is positive, that is, it is in the germline, then definitely the blood relations, okay, they need to be counseled and they need to be tested for early detection and prevention. I mean, early detection and complete cure if possible. Because cancer can be cured if they are caught early. Okay, that is the most important thing. If
Thank
it
you.
is not caught early, then it is a menace.
Yes,
We all know that.
definitely. Yes, yes.
Early detection could not be more than 5% or so. I think that is also too much. Is early detection more than 5-7%? I do not think so.
No, the major. I told you about the ovarian cancer. They are at max. They are always coming at stage 4.
Right.
But ovarian cancer have this BRCA thing. So we are living in darkness. We need to
That is
make
the
people
truth.
aware.
Yeah.
Thank you. Thank you for giving me this platform.
No, think about it. I would request Papia to think about it in terms of what you can talk about, cancer, since you do research. And she is there. I want to run this 2-day course where everybody will be from SNU, the resource persons. I have been asked one question by some very wise person that, do you take money for these courses? Then I said, yes, it's self-finance course. Oh, so it is adding to your salary? I said, yes, yes. It is adding to SNU's fund. We don't take money by our hand. Not even the food we give. It all comes through SNU. That is how we have created a 85,000 surplus from center, which is in SNU. So people are queer, even though they belong to universities. And the person they don't like, of course, want us out, naturally. And they don't want the center because it will show how ignorant they are about other things. Those who do not want, it shows that they are ignorant about other things. Only sociology won't do. So obviously, what we have to do, যদি আমরা এটা রান করতে পারি 2-day, আমি জানি এটা অনলাইন, আমি চাইছি জানুক লোকেরা, 2-day course, interaction between society and the genetics and health, তাহলে পাপিয়া আছে, ও আছে, আমাদের তো ইন্ডিজিনাস। আর এবার আমি সোশ্যাল পার্টটা ইন্ডিজিনাস ফ্যাকাল্টি থেকে ডাকবো, যাতে বলতে পারে তারা, যদি তারা জানে, রাজি হয়। I'll try that. Because আমার মনে হচ্ছে যে একটু ঘুম ঘুম ভাব এসে গেছে। র্যাঙ্কিং কেনা যায় আমাদের দেশে, র্যাঙ্কিং দিয়ে মাথা ঘামানো উচিত না। আমাদের দেশে আমরা জানি হরবকত র্যাঙ্কিং কেনা যায়। সে কেউ 6 মাসের জন্য ভিসি হলো কি 4 দিনের জন্য হলো, কিচ্ছু ম্যাটার করে না। ভিসিদের কিচ্ছু ম্যাটার করে না। আমি 3টে ন্যাক এবং 3টে ইউজিসি ফেস করি 29 বছর বয়সে, 29 বছর ডিউরেশনে আমার। আমি দেখেছি ডিপেন্ড করে হচ্ছে ফ্যাকাল্টি পাবলিকেশনস নয়তো টাকা। ফ্যাকাল্টির যদি পাবলিকেশনস না থাকে প্রপারলি, তাহলে প্রবলেম হয়। এনিওয়ে, আমরা আমাদের আগে ওরটা করে নিই, আমরা ভীষণ দেরি রান করছি। আচ্ছা আচ্ছা, কোয়েশ্চেনটা করে নাও, ঠিক আছে, একটু শর্টে। হ্যাঁ, এই ওকে মাইক্রোফোন দাও। এই অবস্থা কেন?
I'm just asking now, can you just mention the key points if I'm looking for epigenetic modulation in the prognosis as well as prevention of cancer?
Epigenetic. Now you are shifting the entire window from genetic to epigenetic, right? So it's not directly in the gene, it's in the epigenome. That is some kind of a modification of the gene, but it's not mutation. And now you are talking about what you want to see with epigenetics. Can you just repeat?
Lifestyle factors or whatever, how are they playing a role in the prognosis as well as prevention of cancer?
Well, if you need to do a study on that, you have to find out the epigenetic modulators, right? Which particular epigenetic modulation you want to see. They definitely have a role in prognosis, okay? But it depends which cancer is undergoing which kind of epigenetic modulation, because this BRCA gene, they can even revert back, So there can be also epigenetics involved in that BRCA is present, but it is highly methylated, right? So because of that, because of promoter methylation, the BRCA is not expressing. And so there is a challenge. Or maybe in those cases, the inhibitors are working better. but that can even change, because this is something that is not present, may not be present throughout the life of the person, may not be, that may keep changing. Okay, so at which particular window you want to look into, that is important. And the other thing is which particular modulator or which particular epigenetic change you want to focus on, because there are many epigenetic changes. Okay, so which you want to focus on, and then you have to take into account at different time points and then draw a hypothesis. Accordingly, you have to do the research. Okay, so it's very important to look into the time points. Okay, we may talk on this also. Yeah.
We'll have lots of talks, don't worry. Let me first apologize to her, Saroshi, because she's not because of genetic side or preparation side, so she has been pushed for. Actually, my mistake. I should have put you first. That time you'll see what happens. This is the short bio of her. I'm a food scientist with 7 years of research and 3 years of university level teaching experience. Presently serving as an assistant professor in the Department of Applied Nutrition and Dietetics, Nivedita University. Prior teaching experience at Amity University, Kolkata, and at the University of Calcutta, Department of Home Science. I'm completed my PhD as a UGC NET GRA from the University of Calcutta in the subject of food and nutrition. My doctoral work on the 3 lesser known edible flowers of Allium cepa, Carica papaya, আমি কিন্তু জানি না মানেগুলো, Cucurbita maxima, focused on identifying low cost, easily accessible yet unexplored plant pods with medicinal properties. My current research interest includes translating with lab research findings into community settings. I'm also interested in transitioning to in vivo studies, bridging the gap between laboratory findings and real-world application. Wow. I have several publications in peer-reviewed international and national journals and a book chapter with ISBN. I'm most interested in that position, that bridging the gap between reality and theory. It's all yours.
Good afternoon to everyone present here, and thank you, ma'am, for that generous introduction. So at the very outset, I would like to thank the Center for Interdisciplinary Studies and Research, the Center for Corporate and Career Advancement, and the Women Development Cell for organizing this very important event as we are celebrating the International Women's Day. And I would also express my gratitude to Dr. Momita Das, the head of the Department of the Applied Nutrition and Dietetics, for giving me this opportunity to speak at this very important and relevant lecture series that we are having here. So I'll just quickly open the PPT. So veering from the discussion that we were having for the last 2 topics, which was primarily focused on cancer and cancer research, I would like to shift a bit and focus more on the diet and the food aspect of the different stages of life of a woman. So this is a generalized picture of the different stages of life that a human being goes through, irrespective of a male or a female. And we understand here that why a balanced diet is important at the various life stages, starting from infancy and moving on to childhood, followed by the adolescence, and then the adulthood, and for the women, it's the reproductive age group as well. And then, of course, the geriatric stage or the elderly stage. And for each of these different stages, the requirement of nutrients varies. And so my talk is mostly focused on that, why it varies, and what are those variations. So we can roughly divide the life cycle of a woman into these different 5 phases, starting with infancy and childhood, and then followed by the attainment of puberty or the early adolescence. Then, of course, the reproductive age group, which is also the adulthood of a particular woman, and followed by again, a very important physiological change, the menopause, and then finally the attainment of the old age, which is the geriatric stage. So, before I go on to speaking about the different life stages, I'll just focus on quickly these different food groups that has been suggested by the ICMR NIN. And they have clubbed the different food items that we consume on a daily basis into these different 10 food groups. And they have suggested that we keep at least 5 to 7 different groups in a combination form in at least 2 to 3 meals that we take throughout the day. And this will give us all the nutrients required in order to lead a good life, which is what a balanced diet is. So then now moving on to the first stage of life, which is the infancy and the childhood. Here we can see there are 2 pictures. This is again taken from the ICMR NIN textbook, which and in there they have suggested that the diet for an infant between the 6 to 8 months of life and 9 to 12 months of life is pretty much, as we can see here, it's pretty much the same. But of course, the nutritional requirements in terms of the calorie requirement has changed a bit. Like when the infant is a little younger, like between 6 to 8 months of life, and we can start the complementary feeding along with, of course, the continued breastfeeding. The energy requirement is roughly around 650 kilocalories per day. And within that 650 kilocalories, around 420 kilocalories should be obtained exclusively from breast milk. And the rest of the 230 kilocalories are to be obtained from the other complementary foods, which can be like rice with dal, or it could be even a mashed banana, or a steamed mashed apple, or it could be even like a khichdi, which is again a very soft diet, suitable for an infant, with all those whole grains and only a little bit of oil or ghee, which is just about 5 grams as mentioned. And as we shift to a little, as a child grows, as an infant grows, and we move on towards the last 3 months of the first year of life, which is 9 to 12 months, we can see that the energy requirement has increased a bit. From 650, it has increased to 720 kilocalories. And in that, we can find that it's again a very specific and a very prominent change, that the energy to be obtained from breast milk has reduced. In the first, as we can see, the 6 to 8 months, we can see it's 420 kilocalories, but in between 9 to 12 months, it has reduced to 335 kilocalories. And the focus is more on the complementary food, where we get the majority of the calorie requirement from that. As we can see, it's 385 kilocalories, which was for the first 6 to 8 months, it was only 230 kilocalories. So we give more of complementary food, and the foods are also a little more, more calorie-centric and calorie-heavy. Like there are nutri-cereals, and then there are dals, and also fruits, which was also there in between 6 to 8 months. And of course, the oil or the ghee, whichever it is pretty much the same. It's 5 grams in both cases. So this is like a point of difference between the 2 age groups. And this is same, irrespective of whether it's a male child or a female child. It's pretty much the same. So there is no focus on females, at least in this slide. Now, as we move on, this is where the infancy stage has now, is shifting towards more of a childhood stage, which is where we can see that between 2 years to 13 years, if we can divide it roughly between the 3 age groups, all the different food group requirements along with the calorie and the protein requirement has increased over the years. And it is very much visible here. I'm not going to read out all those figures, but I think we can see that the calorie requirement, the protein requirement, the amount of fruits that we consume is pretty much the same between 2 to 8 years. But in the last 9 to 13 years lifespan, we can see that it has increased a lot more. And also the vegetable requirement has increased from 2 to 4 years to 5 to 8 years. And then it remains pretty much same between 5 to 13 years. The amounts are very much similar. And even the grain requirements, the whole grains, it has increased as we age, as we go towards pubertal stage, which is around that 9 to 13 years of age. And these are the different food groups, and associated with that, I've kept the food sources, the commonly available food sources, which are to be kept in a daily diet in order to meet those calorie requirements or the protein requirements or the micronutrient requirements. So at the very beginning, we have the protein, which is very important for a growing stage for a child who is between 2 to 13 years, because this is like where all the major physiological changes in terms of muscle growth, cell growth, the growth in terms of the height, all of that takes place. So the protein requirement is very much important, and it can be obtained from the different seafood, lean meat, poultry, and so on, all the the protein-rich sources. The fruits is very important. It's very important to keep a fruit daily in your diet, at least one fruit. Then the vegetables, a lot of fresh vegetables can be kept. A lot of colorful green vegetables are to be incorporated. A lot of whole grains and whole grain-based food items and snacks like oatmeal, popcorns, and quinoa or brown rice or wild rice. Even the dairy products should be low fat, but it has to be incorporated because it provides with a lot of protein and calcium and vitamin D. Then the food products which contains added sugar, those are to be avoided, and for that we need to check the nutrition labels of the food products and choose only those cereals or food products which says that it has the minimum amount of sugar. The saturated fat is obtained mostly from all those red meat and the fast food items which are deep fried. So obviously those food items are to be avoided, and replacing that with more of a nut-based oil or unsaturated fatty acid rich fishes, or even using all those oils which contains or which is fortified with vitamin E during cooking. And finally, restricting the intake of salt or sodium. It's very important. And how to do that? Just by avoiding processed foods, we can, to a large extent, reduce the consumption of salt or sodium. So now moving on. Yes.
Food, you mean,
I mean something like a burger or a packet of chips or monginis. Yes.
That means fast food.
Yeah, definitely.
But that is even served in the universities and colleges.
Yeah, unfortunately.
Unfortunately.
Yes.
One day I told him in a different meeting that মুড়ি খেলে কেমন হয়?
Yes.
মুড়ি খেলে কেমন হয়? বার্গারের চেয়ে অনেক বেশি স্বাস্থ্যকর, একটু চিবাতে হবে এই যা। সবাই হা হা করে উঠেছিল। এবং এখানেও আমি বলেছিলাম মুড়িটা তো শুকনো, এখানে ড্রাই খাবার, তা মুড়ি চিবাতে হবে আর মুড়ি পড়ে যেতে পারে। সুতরাং আমরা জেনে শুনে, আমি যেটা বলতে চাইছি, ডেলিবারেট কন্ডাক্ট, মিসকন্ডাক্ট রাদার। ইউনিভার্সিটি কি জানে না যে যখন ফাস্ট ফুড দেয়? জানার তো কথা, কিন্তু সব ইউনিভার্সিটিতে ফাস্ট ফুড সেন্টার আছে, কিন্তু মুড়িওয়ালা খুঁজতে হবে এখানে চারিদিকে। একটা মুড়িওয়ালাকে আমি খুঁজে পেয়েছিলাম, সে হারিয়ে গেছে। এত ফাস্ট ফুড সে আর বসে না এখানে। ফলে আমি মনে করছি কি কিছু কিছু লোক জেনে করে। হ্যাঁ, ট্রাকে মুড়ি বিক্রি হয়, কিন্তু মুড়িটা ঝাল হয় বলে আমার ভালো লাগে না। অবশ্যই বলেছি, তাতেও আমার জিভ জ্বালা করে। যাই হোক, আমি জানি যেটা আমি 20 টাকার খাচ্ছি ভেবে অনেক দিন আনন্দিত হয়েছিলাম। তারপর যখন ওরা ঝাল দিতে লাগলো, বোধহয় আমাকে ডিটার করার জন্য, আমি জানি না, মাত্র 20 টাকা। যাই হোক, হোয়াট ইজ মাই পয়েন্ট ইজ দ্যাট এই ফুডের ব্যাপারে আমরা কিন্তু জেনে শুনে পাপি আর কি।
ট্রু, ভেরি ট্রু।
শাস্তির ব্যবস্থা থাকা উচিত।
So on that note, we move on. And this is like a diet chart which can be followed for a child who is of 18 kgs of body weight and between the age of 4 to 6. And this is again given by ICMR. And so this diet would provide the child with around 1,360 kilocalories of energy per day, and would give around 13.8% of protein from this diet. So as we start with the early morning, we can see that there's a breakfast which is to be taken between 8 to 9 a.m. and that would give around 360 kilocalories, followed by a lunch which is of 540 kilocalories, and we can see there is a lot of whole grain based food items, like there can be roti, there can be even rice. Along with that, pulses, vegetables, a lot of leafy greens, and dairy items like curd or paneer, and nuts, and definitely oil should be controlled, which is mentioned here as around 10 grams. And then in the evening, which is 5 p.m., the child should get definitely around 100 ml of milk. And I mean, that can be again replaced for adults with a cup of coffee or a tea. But for a child, it has to be 100 ml of milk. And then, of course, the last stage, which is the dinner. And that consists of, again, a lot of cereals, pulses, and oil and curd and fruits. And then there is also, again, a dairy product like a curd. So what is common between all the meals is that there is a dairy product. There is either a milk or a curd in all these meals, which would meet up the calcium requirements and the vitamin D requirements of the growing child. And also there is a lot of fruits and vegetables in either of the meals. It is distributed, but it is there, whether it's in the breakfast or lunch or dinner, it's there. So this is how a child who is between 4 to 6 years and in a growing stage can obtain around 1,370 kilocalories and around 46 grams of protein. This is again, all these are approximate amounts, and it varies from child to child. And then, of course, the next very important stage of life for a woman, which is the pubertal development, the onset of the menstrual
Sayushi,
period.
before you go to that, I just have one question. Or the audience might be a larger audience in Facebook. That, do you have any idea how many percentage of children of India gets this kind of food?
I think, to be very honest, only a very, very, very small percentage of children probably can afford to have this very balanced.
Let's say not even down double figures, 10% ki khaye? Huh?
Maybe not in a
Maybe
country
not.
like India, which is still developing and maybe underdeveloped. So most people don't. I mean, this is just there, but it's not there in the reality.
Yeah.
I mean, it's
Okay.
all for the papers. Yeah. This is the recommendation given, but it's very sad that most people are not aware. So then comes the idea of following it. They don't even know.
See, we sell through the bureaucratic minded people all these things and do not care whether it percolated or not.
Yeah, yeah.
It is the important part of it that it did not percolate.
True. I mean, they don't really see to it. Yeah.
We can talk about it.
No, it's
but
okay. You can add to that. Yeah.
but this is a recommendation given by
Recommendation,
ICMR,
yeah.
but ICMR NIN itself has different protein, calorie
They have different mixes.
mixes,
Yeah, which they have invented.
ARF mixes, amylase rich food. Then there is balahar. There is different mixers.
Complimentary meal with this, which is promoted in the.
যেগুলো আইসিডিএস সেন্টারে বাচ্চাদেরকে দেওয়া হয় আইসিডিএস ইফ that I really don't know, but
the exact figure we don't really know.
এবং ইন্ডিয়াতে মিডল এজের লোক কম, ফলে সেই জন্যই বলছি কে কাকে দিচ্ছে। Go on.
Yeah, so this was a very important point that
Just
you
mentioned,
pointed
Sreshi,
out. Yes.
after your talk, that this is recommendatory, but how much it actually getting is the biggest question.
Yes.
তার কারণ আমাদের হয়েছে কি, we have everything like law, we have everything on paper.
Yeah, that
You
is the
cannot
problem.
mostly criticize, and that's for politicians and voters. But actual beneficiary, we are not caring that much.
That's the reason why in Global Hunger Index
We are not, yeah.
We are at the very.
Not China. Ha ha. Go ahead. আমাকে এবার আমার
So-
টুক নাম খেতে হবে এখানে।
So yes, this was a recommended diet, but yeah, as Ushmita mentioned, that along with this, we can have complementary foods which can add to the nutrient content of this kind of a diet. And this is promoted by NIN, and they have their labs where they create those mixes and with fixed protein and energy value added to that, and it's it's given to targeted populations, especially in the rural pockets of India where the children are mostly malnourished. So moving on to the next stage, which is the nutrition and the pubertal development, and here we see that
Girls.
yeah, so there are a lot of points here, but I would just say that the nutritional status during childhood, what you're feeding to your child before puberty makes a very significant impact on the onset of puberty, and it also impacts the timing of when the girl will get her first periods, which is, there's a percentage mentioned that as much as 25% of the variations in the timing of puberty depends on the kind of nutrition that she had attained or obtained in her first 10 to 11 years of life, which is before attaining menarche. So, and of course, during the pubertal stage, there is a lot of hormonal changes that takes place, and here we can see that overnutrition and obesity triggers an early onset of puberty, which is because of certain hormones like the luteinizing hormone, the follicle stimulating hormone, the leptin, and the insulin, which is consistently high in the girls who have obtained too much of nutrients, more than they required. So this is overnutrition and obesity impacting early pubertal onset. And of course, these are certain physiological changes that occurs in girls when they attain puberty, with the different definitions there, with the thalagh, the pubarch, the menarche, the ovarian development, and the uterine development, the vaginal changes, and of course, there is a sudden increase in the height of the girl. Which is mentioned here, that linear growth will increase from approximately 5 centimeters per year in the pre-pubertal females to at least 8.3 centimeters in the post-pubertal females. So there is a significant rise in the height, significant jump in the height as she attains puberty. And now we will talk about more on the nutritional aspect of the puberty. Here we can see that there are multiple factors which leads to malnutrition of pubertal girls in the Indian society especially. So firstly, there is a lack of knowledge, nutritional knowledge, lack of awareness in the families and in the communities. Then of course, lack of food in the family because of various socioeconomic circumstances, and also the gender disparity, the inequitable distribution of food because of the male-female gender disparity in the households. Also the poor availability of iron in the diet, certain infections and wrong cooking practices, and definitely the lack of physical activity or physical exercise, a lack of fiber in the diet, excessive consumption of fast foods, digital addiction, skipping breakfast, they all contribute to adolescent obesity and lead to an early menarche. So these are certain factors, and here are the different food items that we will discuss, which plays a key role in puberty. So again, this is a chart. We can see there are various key nutrients listed on the very left with the food sources for each of these different nutrients, and the RDA, or the recommended dietary allowances, as given by the ICMR, and of course the physiological impact of each of these nutrients. For example, if I just talk about iron. Iron is very important for a pubertal female because it contributes to the iron storage of her body, as well as helps in the good regulation of the menstruation, at least at the very beginning. Calcium is required for bone building and also preventing osteoporosis later in life. Zinc is important for growth and sexual maturation. Folate and vitamin B12 contribute hand in hand to DNA and cell growth. Vitamin K is important for blood clotting. Vitamin D, again, very good for laying down bone density or bone mass. And vitamin C, apart from being a vitamin, it's also an antioxidant. So that is also mentioned here, and improves the absorption of non-heme iron, which means not just providing your child with iron-rich food, but also keeping in mind that the child is getting a lot of vitamin C-rich food, because vitamin C helps in the absorption of non-heme iron. So these were some of the key nutrients and the food sources as mentioned there, and the requirements, the amounts, which I'm not too sure how much people follow, but yeah, they are the recommendations that they exist. And then this is what a plate would look like for a girl who has attained puberty, who is between 16 to 18 years of age. And this plate would give the girl around 2,490 kilocalories of energy. And the girl will be weighing something around 56 kgs, which is like a reference weight for a girl who is between 16 to 18 years. And we can see the major chunk of the plate is occupied by vegetables and fruits, which would provide the majority of the nutrients, especially the micronutrients, the vitamins and the minerals. And then the next half is, of course, by the cereals and the nutri-cereals, followed by the pulses and the protein-rich eggs and the flesh foods. And then we have the nuts and the seeds. And a very small amount, in fact, the tiniest amount, the chunk in the plate is to be occupied by fats and oils, followed by an addition of a dairy product, which is, in this case, it's a glass of milk, or it could be even a curd. So this is like a reference menu, which is suggested for a girl.
Only thing you cannot buy it, it's so costly.
So yeah, these are all recommendations.
I understand.
So, yeah,
Indian authorities are very good at recommending, not implementing. দুয়ারে স্বাস্থ্য যেতে পারে তো, যা গি গো অন।
এবারে স্বাস্থ্য মানে ওই যে মিড ডে মিলগুলো হয় তারও অর্ধেক ডিম নিয়ে চলে যায়।
হ্যাঁ,
ডিম নিয়ে চলে যায় আর খিচুড়িটা ওরা পায়।
No, even I know, we went for an.
এই মমিতা এটা মাইক্রোফোনে বল।
I didn't want to this. We went for a survey in a village in Vishnupur, and there the children said that previously we used to get 1 egg, now we get half an egg. Because this is what they said.
আরে অর্ধেকটা কি খায়? পঞ্চায়েত প্রধান নাকি? কতগুলো খেতে পারে?
Maybe 20টা ডিমের জায়গায় 10টা ডিমে হয়ে যায়।
That is the cost cutting.
I understand.
That is not cost cutting.
No,
Actually, that egg comes and it goes to
Their house.
Market.
Maybe their house.
So certain
Or selling in the market in overcharging.
Yes.
even I have some experiences of students giving me information that even the midday meals that are being cooked are shared by the teachers.
ঠিক আছে, যেমনি টিচারদের দিয়ে মাইনেটা একটু কমিয়ে দিলেই হয়। না, গভর্নমেন্টস হ্যাভ টু বি ইনোভেটিভ টু মেক থিংস ওয়ার্ক। আমাদের এখানে ভোট হয়ে গেছে আবার কি? না, তুমি এবার শেষ করো।
হ্যাঁ,
সবাই চলে যাচ্ছে, আমি দেখতে পাচ্ছি, এটা কি খারাপ।
So yeah, this is talking about the pregnancy and the lactation. Again, the next life stage, followed by puberty, and a very important stage for a woman. And here we can see that there is why is nutrition important for a woman, especially during pregnancy, because underweight women are more likely to give birth to a low birth weight baby, and therefore it is significant for a woman, especially at least before conception. It has been seen that the women who are not consuming enough nutrients, especially like iron and folic acid, they already have a very low reserve of these various nutrients. That tends to have a direct impact on the developing embryo and the fetus, the infant that she is giving birth to. So there's a last para here. We can see that if the weight of the woman, the pre-pregnancy weight of the woman also plays a very big role. If the BMI of the pregnant woman is in the normal range, which is 18.5 to 23 kgs, at the time of conception, then at least 10 to 12 kgs should be gained when she has attained pregnancy. And all the underweight women who are having a BMI less than 18.5 kgs to be increasing their dietary intake in order to catch up that weight gain. And women who are overweight and those who are obese, they should aim to gain not more than 5 grams to 9 kgs, which is the rough estimate. So it varies depending upon what the weight of the woman is before conception, the amount of weight that she should gain after attaining pregnancy, it varies depending upon her body weight and BMI. And what does this poor preconception nutrition mean for a mother who is raising an infant? So research has shown that nearly 50% of the growth failure by the age of 2 years is because of poor maternal nutrition between conception and childbirth. So there is a direct impact of the mother's nutritional status on the growth of the child that she has given birth to. And also certain nutrients like iodine, iron, folate, calcium and zinc can result in certain diseases like anemia, preeclampsia, hemorrhage and death in the mothers. And there is also the case of stillbirth, low birth weight babies, wasting and developmental delays in children. And anemia again is very common in women because of very, very low iron reserve and also not, taking those supplements regularly. And that is what is in fact mentioned here, that daily iron and folic acid supplements are currently recommended by WHO as part of the antenatal care. And some of the nutrients again, which are key to a good health during pregnancy and the food sources associated with that. And I've also mentioned the increase in the requirements. For example, the iron. We can see that in case of a non-pregnant, non-lactating woman, it's 29 mg or milligrams. It reduces a bit to 27, but calcium requirement remains pretty much same as that of a non-pregnant, non-lactating woman. The vitamin B12 requirement increases slightly. Zinc requirement again increases slightly. The iodine requirement increases a lot, in fact from 140 to 220 micrograms. And all of them have their own individual physiological effect in the growth of the developing embryo as well as in the health of the mother.
Do we still have most anemic women? At one point of time, India was having that.
I think it has reduced, compared to the early days, yeah.
Like the infant mortality.
Infant mortality, maternal anemia.
Because most women, even among middle class, are quite below from the iron level we require.
Yes, yeah. Therefore, that recommendation of taking those iron polyfer tablets. So, yes, so these were the...
But the tablets cost has come down, so that's why it's affordable now to the low middle class women also. So that has helped that.
Yes, true. So I'll just quickly move on to the next slide. But as we can see that each of these different nutrients plays a key role in the development of the fetus in various ways. One helps in the growth of the bones, the other helps in the growth of the teeth. Then, for example, zinc prevents or reduces the incidences of preterm delivery, etc. So these are some of the key food groups, and the amount is also mentioned with each of them, which are to be consumed, and it is beneficial for a woman's health and fetal development during a normal pregnancy, again suggested by ICMR. And there are various food items mentioned and also the amount mentioned, and we can see that the dairy products are between 400 ml, the green leafy vegetables and the fruits are between 150 grams, the pulses are around 80 grams, and so on.
And pictures look nice.
Yes.
Because affording fruit.
Yeah,
even
it's a challenge.
Good old guava is very costly.
Yes, yes. So yeah, they just recommend, but they don't understand whether people are able to access
Everything
it.
is recommended,
Yes,
but
yes.
not. I mean, they are not doing. Has ICMR done any survey to see that any area, that whether the recommendations has been followed up or how much followed up? ICMR didn't do that. Not that I know of.
They should, I think, in order to understand how much is the
food
impact.
is odd.
Yeah.
Har kono chance nahi.
Maybe they will have some project on that basis and they will survey on the internet and report on the data will be
You
generated.
can apply for projects for this kind of things. ICMR. And you can say West Bengal. Maybe they'll be happy. Take election এর আগে আগে সেন্ট্রাল পাবলিশ করতে দেবে না, সেন্ট্রাল পাবলিশ করতে দেবে, কত সুবিধা পাবে।
বাবা প্রচুর বেশি ফান্ড আসবে, প্রচুর বেশি ফান্ড আসবে।
Yeah, so that was the pregnancy requirement. Now, then followed by, of course, the lactation stage, and that again plays a role in the development of the infant. And so it's mentioned here that during the first 6 months of lactation, an additional 600 kilocalories of energy are to be given, which is for a non-pregnant, non-lactating woman is around 1,660 kilocalories, and adding to that around 600 kilocalories are to be given during the first 6 months of lactation, and 13.6 grams of protein are required in the daily diet for a woman who is lactating. And then that number changes in the next 6 months, and we can see that the energy requirement goes down a bit from 600 to 520 kilocalories, and also the protein requirement goes down from 13.6 to 10.6 grams. And as ICMR says, that it is possible to meet all the requirements for most of the nutrients by just taking a balanced diet. And lactating women are also advised to take daily supplements of iron and folic acid. And these are some of the numbers again, the different nutrients, along with that the recommended RDA. And in the bracket I've mentioned the requirement during pregnancy, so that we can understand how much the requirement increases during lactation. For example, in calcium we can see that in the normal requirement is 1000 mg, but during lactation we add around 200 mg with that, and it becomes 1200 mg. So there is an increase in the calcium requirement. And some of the nutrient requirement goes down, but then for iodine again it has increased by plus 40. So these are just certain, I've added that in the bracket to give us an idea that how much the nutrient requirement either increases or decreases from the pregnancy stage to the lactation stage. Vitamin D requirement remains the same, whether it's the pregnancy or the lactation. And these are the food guidance for a lactating woman, the calcium sources, the zinc sources, the magnesium is again a very important nutrient. During lactation, vitamin B6, thiamine, and folate. So some of the key nutrients which are beneficial for a lactating woman are mentioned here, along with the different food items. And this is again another diet chart for a woman who is non-pregnant and non-lactating. This is just a well-nourished sedentary woman who is whose daily requirement would be around 1,660 kilocalories, and a requirement of protein would be around 57 grams. And the BMI is normal, which is between 18.5 to 23, and the body weight is again normal, 55 kgs. So somebody who is having a normal body weight should again, it's a should consume these different food groups, food items, and keep them in their daily diet, and so that she is able to get a balanced diet at the end of the day. And again, so there are 4 meals, starting with breakfast, lunch, and beverage in the evening, with a dinner between 7 to 8. And here is the next phase, which is of course the menopausal phase. And during menopause, there are certain changes, certain physiological changes which are commonly seen in a woman, which is weight gain, obesity, there are metabolic syndromes, cardiovascular diseases, and there's also the risk of having osteoporosis later in life. So therefore, exercise along with calorie restriction is to be recommended in the post-menopausal woman with excess weight, who is already overweight or obese. So for those women who are heading towards attaining menopause, they should get into some sort of physical activity, and as well as restrict their calorie intake in order to reduce their chances of having any metabolic or any cardiovascular risk. And also going for lifestyle assessment and counseling can help. And these are certain dietary guidelines. So aging or heading towards menopause is a way forward towards the old age. So aging increases dietary protein requirements. So the protein requirement would increase for a post-menopausal woman, which is here mentioned as 1.2 grams per kg body weight is recommended for post-menopausal women, which will help to reduce by 32% the chances of frailty or having a better physical function. And there's also the recommendation of a plant-based Mediterranean diet around this stage of life, which is why is it recommended? Because it contains a lot of plant-based food items, which is full of antioxidants, beta-carotene, vitamin C, and vitamin E, all the antioxidants, and which will help to a large extent reduce the risk of cancer as well as osteoporosis or cardiovascular diseases. And the ICMR anion recommendation of calcium is between 1000 to 1500 mg per day for post-menopausal women. The vitamin D supplements are recommended which would provide around 400 to 800 IU per day, and calcium recommendation is between 1000 to 1200 Ng per day. And this is the supplement, the amount that we obtain from a calcium or a vitamin D supplement. And of course, along with that, the dietary sources are to be incorporated. And this is just a quick overview of a Mediterranean diet, because as I mentioned in this slide, that a Mediterranean diet at this stage of life is beneficial, because it is primarily a plant-based and a whole grain-based diet, with only keeping good sources of fat, like depending on olive oil, and also the fish oil, for example. And therefore, it is a diet which is full of antioxidants, full of beta-carotene, and it's a good source of magnesium as well. And each of these key nutrients have their own specific physiological impact in the post-menopausal woman's body. And at this stage, as mentioned, that in a post-menopausal woman, there is an increased risk of cardiovascular disease. So a low-fat diet, which is only rich in the good cholesterol, should be incorporated in the diet. And again, the Mediterranean diet is again a good example to be incorporated in a post-menopausal diet, which would help to reduce the blood pressure and also keep the risk of developing cardiovascular diseases at bay. And again, since the theme of the today, the lecture session is on the cancer, and there has been a lot of useful information in the previous sessions. Since I'm talking about the post-menopausal phase, I just wanted to just touch upon that there is an increased, it has been seen, research has shown that there is an increased risk of developing cancer around that menopause, when a woman is heading towards menopause, or before, or right after attaining menopause, which is the pre and the post-menopausal phase of woman's life. And why is it so? It's because of the woman who has attained early menarche and who is attaining a very late menopause. Those women, it has been seen that they are at risk of developing cancer in their post-menopausal phase because of a longer exposure to the estrogen hormone. So that research has shown that it is that the woman who have attained menopause at 55, rather than somebody who has attained menopause at 45, those women have around 30% higher risk of having cancer. So that is a matter of concern. And then, what can then women do to reduce their cancer risk during menopause? So there are certain food items which research, again, these are taken from different research papers. So a study in Vietnam has shown that keeping a lot of dark green leafy vegetables, legumes, starchy foods, also a lot of fruits and vegetables in general, and soya bean products can help to reduce the risk of developing cancer. So these are anti-carcinogenic compound containing food items. And also these food items, whether it's the dark green leafy vegetables or legumes or starchy vegetables, are rich sources of dietary fiber, which is again itself an anti-carcinogenic compound. Then again, a study in China by the Shanghai Women's Health Study has shown that women who consume a high amount of soy foods, like the soy milk, tofu, dried soybean sprouts, fresh soybeans, they consistently, during their adolescent phase of life and also later in adulthood, had a substantially reduced risk of pre-menopausal breast cancer. So these are examples of food items having an impact of whether the woman is going to develop or not develop cancer during their menopausal stage. And soy isoflavones, as we mentioned about certain soy products there in the third point. So these soy isoflavones are the active compounds that are very similar in terms of their structure with the hormone estrogen. So therefore, it has been seen that the women who are consuming a lot of soy-based food products, they tend to be having a lower risk of developing breast cancer, because this particular active compound mimics the role of estrogen and suppresses the action of estrogen, which, as mentioned in the previous slide, can result in a longer exposure to estrogen can result in cancer. So incorporating a lot of soy isoflavone-rich food items in the diet can help to reduce the risk of developing cancer during menopause. and the last stage of life, the geriatric stage or the elderly stage. And it's just, again, a very brief overview of what are the changes and how a diet can play a role. So at this stage, there is an impaired digestion, protein utilization, and there's also altered body composition, insulin resistance, inflammation, and a decreased bone density. So these are the physiological changes that takes place naturally in a woman after after 60. So the recent studies have shown that a 0.7% decrease in metabolism per year is noted in women who are above 60. An elderly person needs fewer calories but more micronutrients, which is the vitamins and the minerals, than someone in their midlife, which is that 40 to 50 age. And hence elderly people require less energy but more micronutrient-rich food items to be incorporated in their daily diet, which includes the fruits, the vegetables, the beans, the nuts, the whole grains, a lot of fish and eggs. So these are all micronutrient-rich food items, and these do play a very important role in the well-being of an elderly woman who is around 60 years or more. And again, this is suggested by ICMR. It's a table where we can see a lot of food groups and the exact amount, which is the recommendation for an elderly woman who is around 55 kgs of body weight, and the different food groups on the left side and the different key nutrients, whether it's the protein or the fat, or whether it's a vitamin or a mineral. They all have their specific recommendations, and we should adhere to this. And finally, this is where we can see it's again a diet chart, a daily menu for a woman who is more than 60 years of age. Around 56 grams of protein can be obtained from here, and around 1530 kilocalories of energy can be obtained. And we can see that the breakfast, lunch, and evening beverage and the dinner is distributed throughout the day, where the calorie requirements are again distributed for each of these different meals. And it's a well balance of different fruits and vegetables, a lot of micronutrients, microgreens, and there is also a dairy product which has been added to each of these 4 meals throughout the day. And so that's all. I just wrap it up. Thank you so much for this opportunity.
Because this has to be repeated, I believe, কারণ যারা আমরা শুনলাম প্রায় নিউট্রিশন আর 1-2 তাই তো এরকম একটা ব্যাপার দাঁড়ালো। মানে আরেকটা কথা আমি দুঃখের সঙ্গে বলছি, এটা আমি অনলাইনই বলছি, আমি কিন্তু ভাবিনি যে এসএনইউটা এত মেল শোভিনিস্ট। আমি সত্যিই ভাবিনি। আজকে আমার একটা ঘুম ভাঙলো আর কি, কারণ আমরা সেমিনার হলে করতাম তো বোঝা যেত না কে এসছে কে আসেনি, আজ কিন্তু বোঝা যাচ্ছে। এই হচ্ছে মানে কি বলবো, বায়নাকুলার। Thank you, Sreshi. It was very actually informative, but make sure we are going to do it. আমি এবার সত্যি কথা বলি, বন্ধ করে দিতে পারি, বন্ধ করে দিতে পারো হয়ে গেছে এখন।